So Indian Society of Oncology decided to organize a meeting here in Bombay, but which is being widely telecasted. I welcome you all on behalf of President ISO Dr. Ramesh Bilimaga and Secretary ISO Dr. Arvind Krishnamurthy, and I, in my capacity of past President ISO, I welcome you all here. Breast cancer is challenging. It is number one in our metros. We see more than 150,000 patients new per annum. There are many early diagnostic facilities becoming available. So there are more and more patients coming up in early stage. There are more and more treatment options available with us. So it's good for the patients, but it's a challenge for us as the physicians, because sometimes it's really not easy to choose between the options. So I'm sure today's meeting, which Viatris has kindly agreed to support us, support ISO, and I'm sure with this meeting today, we'll be able to bring some light to the new dimensions in breast cancer. To initiate the meeting, I would like to invite for the lamp lighting ceremony, Dr. Ashok Vaid, Dr. Martin, Dr. Basade, Dr. Rajiv Arora, and Dr. Dhara, and Dr. Radhesham. Please come forward for the lamp lighting ceremony. Thank you very much. Now I would invite Dr. Ashok Vaid to take over from there.
Good morning, friends, and a very warm welcome to this meeting. At the very outset, I thank Dr. Pendarkar and ISO for creating this platform, and Rajiv and his team, Dr. Naik, and everybody at Viatris for taking this concept forward. Friends, we know that breast cancer is such a heterogeneous disease. The biology is so heterogeneous, and the combinations and permutations which evolve in the clinic are so very many. HER2 positive disease is in itself a subset. Triple negative is a great challenge once it comes back. The therapeutics are advancing, and the biology of the disease is getting unfolded in a manner that we are able to target the various cancers within the breast cancer domain much more efficiently, but a lot of work needs to be done still. There are issues, unresolved issues, I would say, still in the neoadjuvant setting for both the HER positive as well as the triple negatives. Adjuvant setting is more or less been crystallized to a great extent, and then all of us have a very uniformity of the practice in the clinic. But what happens once the neoadjuvant is done? There is a residual cancer burden. There are challenges there in choosing the right treatment, the right antibody. And of course, once the disease comes back, there are greater challenges in terms of the previous treatments, the toxicities, the treatment-free intervals, so on and so forth, the choice of the hormonal agent and the partner drug in the metastatic setting. And I'm sure the proceedings of the day will throw light on that. We have very eminent speakers and also a guest speaker joining from abroad. Friends, let's take this opportunity to convert this into a more interactive session so that we learn from each other. And at the end of the day, it's the patients who benefit with our advancement of the knowledge. Thank you so much. Have a great meeting. Thanks for coming all the way. And thanks once again to the organizers.
Can I have my slide set, please? Wait. Couple of slides before, yeah. Okay, great. Thanks. Yeah, that's good. Good morning, everyone. Thanks, Viatris. Thanks, Rajiv and his team. Thanks, Dr. DP. Uh, thanks, Dr. Ashok sir, for having me on board. It's a pleasure and an honor to be here. And as Dr. Ashok said, uh, the management of breast cancer, especially HER2 positive breast cancer, has undergone a revolution, if I can say, in the last 20 odd years. For the longest time, breast cancer was divided into early breast cancer, which used to be the surgeon's domain, versus metastatic breast cancer, which used to be a medical oncologist domain. Now, finally, in the last 15-20 years, especially in the early 2000s, that's when I think Herceptin first came into the markets. I mean, when we were training, that's when Herceptin first came into the market. And from that time, every few years, we know that there are a lot of changes which are happening. So it's a pleasure to be talking about sequencing of treatment in early HER2 positive and triple negative breast cancers over the next 20 to 30 odd minutes. So it is an achievement for all of us in this room if we are talking about sequencing of treatments and not just treatment of HER2 positive breast cancer. So that's how far we have progressed as a community. So we know that the prognosis of HER2 positive disease is quite poor without trastuzumab. There is a decidedly worse survival if a patient has HER2 positive disease and is not treated with the appropriate targeted agent. The pivotal trials which showed that targeting this particular pathway, adjuvant trastuzumab, did improve DFS and overall survival in HER2 positive early breast cancer. The three trials were the HERA trial, the NSABP3B31 trial, and the BCIRG trial. All of them, you can see the delta, the survival differences where I mean, the least was at least 6.5%, and the most was nearly 10-11%. And this is, to put it in a context, the benefit of adjuvant chemotherapy was barely 5-6%. So there is a significant difference if we identify the biology of the disease and treat it accordingly. So let me start off with adjuvant treatment of patients with lower risk HER2 positive breast cancer. So basically, how do we define a lower risk HER2 positive breast cancer? Even if a patient has T1A or T1B N0 disease, if they are HER2 positive, they have a worse prognosis when they compare to the hormone receptor positive breast cancer. So it's not just the stage of the disease, it's the biology of the disease which also influences survival when we talk about early breast cancers. So to address this very unique subset of patients, now I know that in India we probably don't get these many. In the West, in the US, there is a very robust screening program, and because of such a robust screening program, we do get quite a few early breast cancers. But in India, in the absence of a robust screening program, we might not get so many. But if we have a patient with a small, less than 3 centimeter node negative HER2 positive early breast cancer, here we have the APT trial, which is a prospective non-randomized trial in patients with a tumor of less than equal to 3 centimeters, N0, and completely dissected N1 micra. So the patients were put on a plan of paclitaxel, which is 80 mg per meter square, with trastuzumab 2 mg per kg weekly for 12 cycles, followed by trastuzumab for 1 year. So again, this is not a duration trial of the trastuzumab. The trastuzumab does remain the full 1 year, but it was an attempt to try and cut down on the chemotherapy that patients with such a good risk are going to receive. As you can see, there was a fair bit of heterogeneity in the sizes of the patient, size of the tumors of the patients in this particular study. About 67 patients were HR positive. 67% of the patients were hormone receptor positive also. So there was a fair bit of heterogeneity, and we could potentially extrapolate this into a day-to-day clinical setting. So in this trial, whenever we look at a Kaplan-Meier curve, when we see parallel lines, we know that something is really going to stand out in this trial. So here we know that be it HR positive or HR negative, with the 3-year DFS, with just a very abbreviated dose of paclitaxel and the 1 year of trastuzumab, got a 3-year DFS of nearly 98.5% and a 7-year DFS of 93.3%. Now these are numbers which are definitely good enough for us if we can translate it into day-to-day clinical practice, and hence this trial did pave the way for abbreviating the dose of chemotherapy. So I mean, man is greedy by nature. So in our greed to try and eliminate, or so-called tell the patient, no boss, you don't need chemotherapy at all, I am going to give you a particular targeted agent which is going to combine with the chemotherapy backbone, and put it onto a targeted agent so that we can potentially reduce the amount of side effects that you have. So for patients with very early breast cancers, there was a trial, or there was an attempt made at a phase 2 attempt trial, which looked at replacing paclitaxel with TDM1 in the adjuvant setting. Now the primary endpoint of this trial was to look at whether the patients had a lower amount of toxicity on the experimental TDM1 arm if it was used as a adjuvant agent. Now, although you can see that the 3-year DFS in both the arms were quite excellent. In the TDM1 arm, the 3-year DFS was 97.7%. But when we looked at the actual endpoint, so that this trial did not meet its co-primary endpoint, which was a 40% relative risk of reduction in toxicity with TDM1. So this trial taught us something very important. If for whatever reason we think a patient is not fit for paclitaxel with trastuzumab, then they are also not fit for TDM1 in the adjuvant setting. So that's something that we need to understand. For whatever reason, we cannot assume that TDM1 is any less toxic than maybe pacli with trastuzumab. So various grades of toxicities were there. I think the one number which sort of stood out to me over here was that you can see over here, any toxicity requiring early discontinuation, just 17% of the patients in this trial. So that sort of did stand out to me, and that's the reason why this trial sort of failed. So moving on from the adjuvant setting to the neoadjuvant setting, why do we need to give neoadjuvant systemic therapy? The principles are as follows. We want to reduce the tumor size, increase the chances that the patient can have a breast conservation rather than a full mastectomy. At the same time, we would also want to treat patients at high risk of metastatic disease with systemic therapy without any delay, and HER2 positive breast cancers do sort of fit into this particular subset. This also allows both the patient and the doctor to see if this tumor responds to treatment, a sort of a de facto response guided approach, which is becoming the norm these days. Also, this helps in assessing the pathological response at surgery, which is the residual cancer versus PAT-CR. And no difference in survival was seen if we are comparing if patients went on neoadjuvant versus adjuvant. So the idea here was not to see if we could achieve a better survival if patient went on neoadjuvant versus adjuvant. The idea was to look at all of these other factors. So why did pathological CR become such an important surrogate marker for us? So in this CT Neo BC pooled analysis, this showed that there was a definite association between pathological CR, event-free survival, and overall survival. In fact, even if we look at the hormone, especially when you look at the hormone negative status, if a patient did achieve PATH-CR, then there was a 75% chance that they would live longer compared to patients who did not achieve PATH-CR. So this did established established PAT-CR as a very important surrogate marker when we treat our patients. So who should be considered for pre-operative systemic therapy for early breast cancer? Let's make no confusion about this. Patients with HER2 positive early breast cancer who have a tumor of more than or equal to 2 centimeters, which is a T stage of T2, or those who have node positive disease, regardless of the hormone receptor status, they should receive neoadjuvant chemotherapy with trastuzumab or pertuzumab. So now moving on to the trastuzumab and pertuzumab in this particular setting. So the pivotal trial for this, for the neosphere trial, this looked at neoadjuvant trastuzumab with pertuzumab with chemotherapy. Did it increase our PAT-CR rate? So if a patient went on the THP arm, the PAT-CR rates were nearly 45.8%. Then came the trifina trial, and this basically looked at, the PAT-CR rates if a patient went on the TCHP arm. So TCHP patients, and if patient were hormone receptor negative, there was a 83% chance that they would achieve a pathological CR. So hormone receptor negative early breast cancer, if we give them TCHP, 83% chance that the tumor would vanish just with chemotherapy and target therapy. So that is definitely something that not only would we want as clinicians, we want to explain that to our patients sitting in the clinic. So this is how we translate trial into clinical practice. And even if the patient was HR positive, which we know confers a fairly less amount of responsiveness to all this kind of therapy, even in that scenario 50% of the patients did achieve some kind of pathological CR. So this did establish that a combination of trastuzumab and pertuzumab in the neoadjuvant setting is the standard of care. Moving on to adjuvant therapy for patients with a higher risk of HER2 positive breast cancer. How do we build onto the gains that we had? So trying to build onto the trastuzumab, additional HER2 targeted therapies in the adjuvant setting. Neratinib was the first drug which was looked at. Neratinib achieved FDA approval in 2017. This achieved FDA approval as an extended adjuvant treatment for patients with HER2 overexpressed early breast cancer post trastuzumab therapy. Then came the approval for trastuzumab with pertuzumab, and by and large this was for adjuvantry. If we want to use pertuzumab in the adjuvant setting, we might want to use it for high risk patients which were basically either hormone receptor or node positive breast cancers rather than the much better risk patients. Then came the most exciting trial, which is almost become standard of care, which is the Catherine trial, which is the approval for TDM1 in this particular setting. So I'll go very briefly into all of these trials. So Affinity was trying to look at pertuzumab in the adjuvant setting versus placebo. The 3-year differences, IDFS differences was not very great. Even at the 6-year mark, the IDFS difference was just about 2.7, 2.8%. When we look at the nodal status, if a patient was node positive, then we know that this was a statistically significant gain where the stratified hazard ratio was 0.72. Whereas if it was a node negative cohort, then there was no statistical significant gain if we gave pertuzumab in the adjuvant setting. So this established that if we have used pertuzumab in the neoadjuvant setting, and if the patient is node positive, maybe then we continue it in the adjuvant setting. But if the patient is node negative, then probably it's not the right thing to continue pertuzumab. We can just do away with trastuzumab alone. So when we looked at the hormone receptor status, again in the HR negative setting, the hazard ratio here was not significant with the confidence interval crossing the unity line. But when we looked at the HR positive cohort, here the stratified hazard ratio was 0.73, which did tell us that we have to use pertuzumab in the adjuvant setting as well. Then came the pivotal trial for the neratinib. This was the XTNet 5-year update. This looked at patients who were HER2 positive, early breast cancer stage 1 to stage 3, who had any node plus or node negative disease or residual disease after neoadjuvant chemotherapy. They were randomized to receive neratinib at a dose of 240 milligrams per day for 1 year versus placebo. The primary endpoint for this was the IDFS at 2 years. When we looked at the primary analysis of 2-year IDFS rates, neratinib had a 2-year IDFS of 93.9% with the placebo of 91.6%. Although this was statistically significant, probably this has not caught on to us so much, and this is predominantly because of not just difficulty in availability of this molecule in India, but also because of the perceived toxicity. The data shows the diarrhea rates and the patient tolerability rates and the patient dropout rates whoever went on to neratinib was very, very high. So we also need to keep in mind that when we want to treat a patient in the adjuvant setting, we need to be very clear as to how much of treatment we want to give and how much of a disruption to their day-to-day life we want to do. So adjuvant molecules, we need to weigh not just the benefit, along with that the cost to the patient as well needs to be weighed out over here. Then came the pivotal Catherine trial, which looked at TDM1 in the adjuvant setting. If a patient did not attain pathological CR after neoadjuvant chemotherapy, here there was a marked difference in the invasive disease-free survival. The 3-year IDFS for anybody who went on the TDM1 in the adjuvant setting, the 3-year IDFS was 88% compared to 77% of so the delta here was nearly 11%, and the hazard ratio is 0.5. I mean, to put this hazard into context, this is a curative cancer that we are talking about. Most of the times chemotherapy trials hazard ratios are barely 0.8, 0.85, 0.9, and we are already quite excited by that. So this is not something that we can ignore, and this has entered into clinical practice. So any patient with HER2 positive breast cancer who has not achieved a pathological CR with neoadjuvant treatment should probably transition into TDM1 in the adjuvant setting. When we looked at the overall survival, it was not yet mature, and that's the reason why there is still some skepticism to this. Hopefully in the coming years we'll get some better overall survival data also of the Catherine trial. Then there was another very interesting trial called the Caitlin trial. So this trial basically looked at TDM1 with paclitaxel after anthracyclines, and this trial failed to meet its co-primary endpoints. Although there were no new safety signals seen, there was no significant survival benefit. So the idea of combining TDM1 with pertuzumab, there is still not enough of data to say that. So trying to put the data of all these trials into a context, this slide sort of summarizes all of the HER2 positive scenarios that we have. There is the XTNet trial, which vouches for neratinib. Although there is a IDFS benefit and the hazard ratio for this is 0.73, this is something which needs to be considered with a pinch of salt. Then there is the affinity trial, which looked at pertuzumab in the adjuvant setting in particular subgroups like hormone receptor positive or node positive disease. This is where we would want to give pertuzumab in the adjuvant setting as well. Then came the Catherine trial, which was sort of practice changing, which looked at TDM1 in the adjuvant setting, and there was a very significant 3-year IDFS benefit with TDM1. So the proposed strategy for managing patients with stage 1 to stage 3 HER2 positive early breast cancer is going to be, if the patient is T1A or B, then yes, upfront surgery is the right way forward. We can potentially try and put them on the APT protocol, which looks at paclitaxel with 1 year of trastuzumab. If the patient is T1C, then we need to assess the risk and patient preference. So that is a dialogue to be had in the clinic. But anybody who is T2 or N1, straightforward, it has to be neoadjuvant therapy. Neoadjuvant therapy ideally has to be TCHP. If cost is a constraint, then it is going to be TCH. If there is residual invasive disease post surgery, then TDM1 is the standard of care over here. If just give adjuvant trastuzumab, but if the patient is hormone receptor positive, it's reasonable to look at trastuzumab with pertuzumab in the adjuvant setting. Neratinib, some benefit if the patient is HR positive, but that is still yet to be seen in our own clinical context. The last part of my talk is going to be tripling it through this in the next few.
Recording in progress.
quickly looked at, the invasive disease-free survival. This observed that the hazard ratios were quite significant if the patient received both anthracyclines and taxanes in triple-negative breast cancer. So, just quickly moving on. What we are more interested in is what is new in the last 3-4 years. So what is the optimal treatment for small node negative triple negative breast cancers? So if there is a stage 1 disease, there is a simple chemotherapy regimen, either AC, TC or CMF. Usually sequential anthracycline taxane is what we probably would want to do. Is there a role for platinum in neoadjuvant or adjuvant management of triple negative breast cancer? This is a topic which is for huge debate, and people have been debating this for the last 4-5 years. There is the Japar 6-2 is the one which is being quoted very frequently over here, and the CalGB 40603. The trial schemas are there on the slide. Whether to use platinum or not was the question over here. Basically, there were mixed results in these two trials. So the Japar 6-2 3-year DFS survival, there was an improvement if carboplatin was added. However, when we looked at almost a similar setting, the CalGB 40603, the 3-year EVS did not show any improvement with carboplatin. Here the hazard was 0.8, but it was not statistically significant. So achieving PAT-CR is a good surrogate for long-term outcomes on a patient level, but there is no evidence that PAT-CR can be used as a surrogate for survival on a trial level to compare regimens in triple-negative breast cancer. So what about platinum usage in patients with inherited BRCA mutations? So if a patient has a pre-operative cisplatin as a pre-operative therapy in patients with BRCA mutations, this was a very small study. This looked at about 107 patients with BRCA mutations. Again, early breast cancer, curable cancer, stage 1 to stage 3 disease. This looked at pre-operative cisplatin at the dose of 75 mg per meter square. A very simple pre-operative chemotherapy regimen. Just with cisplatin, if a patient was BRCA1 mutant, the PAT-CR rate was 61%. So that just proves that platinums have a very distinct role to play if a patient is BRCA1 positive, and probably BRCA status cannot be taken as a surrogate for triple negative status right now in management of breast cancer. TNT trial, this also looked at carboplatin over here, and docetaxel versus carboplatin was also looked at. Essentially, that is the area which is still up for debate. The final part of my talk is going to be about the immunotherapy in early stage triple negative breast cancer. I-SPY showed that estimated PAT-CR rates and EFS by PAT-CR, there was some correlation in the triple negative breast cancer setting. The pivotal trial again here was the Keynote 522 trial, which showed that the primary endpoint for this trial was pathological CR. So if a patient did receive, there was nearly a 14% chance higher of achieving a pathological CR as compared to no pembrolizumab in the neoadjuvant setting. I'm sure the next session is about all of this, so I'll not spend too much time on this. So I am Passion 031 will be discussed. Japar Neo will also be discussed. So to summarize everything, in general, high-risk triple-negative breast cancer should be treated with a sequential anthracycline taxane-based regimen. Patients with stage 1 disease who are at a lower risk can comfortably be managed with AC or taxane with cyclophosphamide. A variety of new treatment approaches are under evaluation, including immunotherapy, PARP inhibitors, and platinum. Triple-negative breast cancer remains a challenging area and one that is ripe for intensive translation and clinical research. Thank you all for a patient listening. I'm happy to take questions.
How do we take the questions from the audience?
I think Mehboob is doing a panel discussion. We can do.
Okay, so thank you, Dr. Aditya, for that wonderful presentation and hitting out the key points about the early disease and the sequencing very well. Just a piece of information which I would like to share with everyone. There are close to 500 online registrations at the moment who are active and who are involved. And I take this opportunity to invite my friend Dr. Mehboob Basade to moderate the panel discussion. And he will be inviting the panelists. Just a word about the real world experience about both the neoadjuvant TCHP and the affinity. We have a poster in the coming SABC on 116 patients on TCHP. Our experience in the real world has not been very great of the PATH CRs. Probably our disease load is high, and we have been using in node positive, clearly node positive patients. The PATH CR are much lower than what the trials showed us. And affinity, three things: cost, GI toxicity, and cardiotoxicity. These are real world problems. We have about 15 patients on affinity in the last couple of years, but we are not really very excited about the pertuzumab in the adjuvant setting. So Dr. Basade is a consultant medical oncologist at the Jaslok Hospital and Research Center, Mumbai. Over to you, sir.
Thank you, Ashok. And thanks everybody for inviting all of us over here. I'm supposed to moderate the two sessions. So there are some questions to Dr. Murli. Murli, where are you? Yeah. So there are three questions, but one is for the HER2 positive, the HR positive. So I won't go. So what are the indications for upfront surgery in TNBC?
I think the only indication today for upfront surgery in a triple negative breast cancer would be a T1 disease.
T1 disease, okay. And the other is from Dr. Arvind Chaturvedi. He's saying that if PATH-CR can be predicted by some AI tool or imaging, will surgery be still required? The surgeon is also there in the audience. If surgeon wants to take this.
Yes, please.
Dr. Sivaram? So the question is that if you can predict PATH-CR, and we know that PATH-CR patients do very well in triple negative, can you avoid surgery?
I hope the day doesn't come that way.
Same here.
One. And because I'm the solo surgeon, I'm representing an entire community or the universe. Okay. So likewise, we need to understand breast cancer as a disease. Our evolution, our thought process is evolving. There is a definite disease called DCIS, which is even smaller or preceding a T1 cancer. So at that moment, and the treatment of that is surgical. So even surgery has a definite role. And the question for the earlier question was an emphatic T1 from the surgeon. And in the real world, we all know in early breast cancer, we are looking at optimizing the treatment. The idea of sequencing is to optimize and get the maximum from the patient with minimal complications. So how do we do that? And there are an umpteen number of other complications, like how do we do about the nodes? In fact, we want to say about predicting a PATH-CR, but how do we predict the nodal status with certainty? How do we, so there are a lot of variables, and forever there will be a role for surgery. And in many ways, surgery is a simple way out. Whenever we choose neoadjuvant, we also choose the associated complications in the treatment process.
Thank you. Thank you, Dr. Sivaram. And surgeons are not out yet, but de-escalation is definitely happening. So for our panel discussion, thank you. Thank you, Murli. Let me invite Dr. Abhishek Kakru. He's from Ahmedabad, Vedant. Medical oncologist, Dr. Rajesh Kar. He's a radiation oncologist. Dr. Kiran Tamkhane, medical oncologist, and Dr. Sivaram again, surgeon on the panel. So we are going to discuss about the early HER2. Now we just, Dr. Murli just showed us the very nice presentation about both HER2 positive as well as the triple negative. So we will see in practice how do we apply that knowledge. Okay, so the there will be one case discussion and we will go ahead with that, and questions can come in from this audience or from the audience who are having a virtual presence. So the first case is about inoperable HER2 positive early breast cancer. Okay, here is a 65-year-old postmenopausal woman with stage 3A, that is T2 and 2, M0, HER2 positive, and hormone receptor ERPR negative cancer. She has a good health, good performance status, and no comorbidities. So let me start with surgeon first, Dr. Sivaram. This patient, now most of the time the patients go to the surgeon first. So what would you do?
So I would consider this as a LABC, right? N2.
Okay.
So we would definitely, no doubts on this. She needs a neoadjuvant treatment. So the plan will be to optimize her. Her health is better. So start with neoadjuvant treatment.
Okay, so neoadjuvant treatment, and that will go to the medical oncologist and I think. Do you do some clippings at the beginning, or what happens to know
For
the tumor?
early
Because
breast cancer, yes, that will be a consideration where we expect PAT-CR. The idea is to anticipate. The idea of giving a neoadjuvant in early breast cancer is very different than in this scenario. So in a N2 disease, we may not. Ultimately, she will need axillary lymph nodal dissection. And the idea will be to try to get maximum control. So in a T2, in a 65, probably not for this lady. Clipping is not.
no, if the patient sees a good performance status, and there are patients in Mumbai, we see that they want breast preservation.
Breast conservation may be possible, but I'll not be starting with the timing of it. The idea here is to start the treatment as early as possible. So once we have all this information, clipping, we'll be monitoring the patient. It's very important that when the patient is on neoadjuvant treatment, the surgeon is so actively involved in the clinical decision making and also seeing the patient. So probably by the second cycle, we'll like to have a examination and then decide on clipping if the response is excellent.
Okay, so Abhishek, what do you do?
How would you, suppose she is hell bent on a BCS, how would you do that after 6 cycles if she's in a PAT-CR?
Not cycle, I said second.
No, suppose, so neoadjuvant if we are giving, that means we are considering TCPH, so we'll finish 6 cycles. After that, if everything is disappeared,
there is no way.
Clipper.
There is no way. In fact, at the moment, PCR, though we are all aiming for PCR as a surrogate, we should understand that ultimately our broader or realistic aim is to cure the patient in the long run. So BCS, if she is very hell-bent, we will be doing it we will be discussing it at the outset. At the end of 6 cycles, when there is no tumor, if she wants BCS, then the treatment, there is no standard way of doing it.
So you'll have to do a clipping then, day one.
Ideally, yes. Not for, see, let me be very clear. If it is an early breast cancer, node negative, then we will clip the primary tumor. If it is an early breast cancer, but with a nodal involvement, we would like to clip the node as well as the tumor at the outset, if it is a T1 tumor. If it is a locally advanced tumor, then we would like to see the patient slightly, if she is responding, and then she is likely to become a candidate for future, we would like to usually take that decision at about the second cycle.
Dr. Chetan.
Yeah, so we do a lot of clippings in Pune. Dr. Kopikar is very well known for this technique. When the patient reports that she is unable to feel that lump, we put in a clip. That is a good guide. As long as you, of course, assess the patient every 2 cycles. But the day the patient tells you that today I could not feel the lump, that is a good time when you know that the tumor is around less than 1 centimeter. And that is a good time to put in a clip so that this question that if there is a complete response, you don't have to subject the lady to a mastectomy when the whole purpose was to make BCT feasible.
Okay, so let's go ahead. We will have further questions also. Abhishek, how would you go ahead with this patient with you?
So obviously she is an stage 3 LABC, so we'll be going with a dual anti-HER2, that is TCPH, would be the ideal regime in our case, considering fitness and finances.
Okay. Kiran?
I agree with Dr. Abhishek sir. So definitely she will require neoadjuvant chemotherapy with TCH. If affordability is not issue, then I would like to add the pertuzumab.
Okay, TCH, dual HER2 agent with
Dual
chemotherapy.
HER2.
Would you like to go for TC as a chemotherapy or AC followed by T?
No, TCHP.
TCH because of 65?
Yes, sir.
So enough data to suggest that you can omit anthracyclines.
Okay, yeah. Anybody from the audience? Okay, so this lady was given carboplatin, docetaxel, trastuzumab and pertuzumab. totally 6 cycles, and then she underwent the lumpectomy with the axial node dissection. Again, I will come back to the surgeon, Dr. Sivaram. Is this the right approach?
Yeah, I would
Lumpectomy
agree with this
section?
because it is fair enough. Earlier, when breast conservation initially came into vogue, N2 disease upfront would have been a contraindication, but now this is pretty standard. So,
So,
to
sir,
exercise to clear margins and then ready for the adjuvant therapy. That should be the way.
okay, so the surgeon has done the surgery and there is a complete pathological response both in the breast as well as in the lymph nodes. Now, the patient is with the surgeon. What will you do? Will you send to the medical oncologist to complete the therapy, or will you send to the radiation oncologist?
Definitely, no question on that. The patient, once the wound is ready, she goes back to the medical oncologist.
Okay, radiation. Dr. Abhishek. Sorry.
Yeah, of course.
Rajshekar.
This is the scenario, Rajesh. Sir. So this is a scenario where definitely radiation is required. Sir. There's no doubt about it. Even though there's a complete response, we have been treating patients, and there's the NCCN guidelines for that. Even the RTOG guidelines says that the patient needs to be treated with the radiation if there's going to be lumpectomy with the complete response.
Okay, so the radiation will be given to the patient and concomitantly. Now, again, both the medical oncologists, what would you like to give?
So it's a node positive disease or an N2 disease from the start. So we'll complete and ideally the dual anti-HER2 for the next 1 year.
Okay.
Agree with Dr. Abhishek. If the cost is not concerned, we would like to continue the trastuzumab with pertuzumab for 1 year.
So that was trastuzumab and pertuzumab for remaining 9 months of the therapy. Total 1 year of therapy. That would the choice of our both the panel members. Now, this is the data which has been published. It is very important that to note that the impact of HER2, there over a period of time, we always discuss about a short duration of the anti-HER2 therapy, trastuzumab. But if you look at the HER2 gene as such, its impact lasts over 5, 6, 7 years. When I was a resident, Ashok will also remember that tamoxifen was the only drug, and there are many trials shown that beyond 5 years, tamoxifen has no role. So I used to wonder whether the impact of that ER positivity goes away after 5 years. That means that there is probably we didn't have a good drugs to do that. That may be the thing. So if you have an HER2 positive, how long you would like to go ahead and give the therapy? That is very important. From this trial, from this study, you can see that the impact of HER2 is even a longer period of time. So how many takers are there for the short term? So let me ask Abhishek.
So there's only one trial which showed us that you could give a shorter course of 6 months, but as of today, standard of care remains 12 months of trastuzumab or an anti-HER2 therapy, and there is no what I would say convincing data to tell you that you could use a shorter course of 6 months in a patient. Maybe a very early tumor and a hormone receptor positive tumor, you might try it, but then it is 12 months.
Okay, Kiran.
Sir, total 1 year trastuzumab with
Total 1 year. Anybody here for 6 months of the trastuzumab or in 9 weeks of the trastuzumab in adjuvant? Yes, Nilesh.
So in very early tumors, a T1, T2 node negative ER positive, I would definitely consider. I think we have analysis from Dr. Sudeep Gupta also suggesting that this is a group of patients who might benefit from de-escalation. But since the landmark trials have shown that there is no non-inferiority, standard would probably be 1 year. But these are the set of patients where I would consider a shorter dose.
Okay. So there is definitely some role even by the trials which have been there. I will just show you those trials. That shorter duration of anti-HER2 will also have an impact on the overall survival as compared to chemotherapy alone. Now, as we have an oncotype DX, there is an HER2 DX which is also available now. Though it is still, the early data has been getting presented. I just came from the ISMO, and in the ISMO they have presented data of the HER2-DX, and you can see this year January is the Lancet Oncology. There is also an article of HER2-DX and impact of HER2-DX study in the HER2 positive, like Oncotype DX is in ER positive and HER2-DX is in HER2 positive. So they have classified this HER2 positive into the two, low risk and high risk, and they did typically in shorter trial. Shorter trial is a shorter duration of 6 months of the duration at this. And what they found that the patients who are having a low risk HER2, depending on that HER2-DX assay or analysis, you can say, they have a 97% of an response as compared to the patients who are having a high risk of the HER2 analysis, which was somewhere around 85 or 87. I don't remember the exact figure, but that means that as we could divide our patients in ER positive into the low risk and high risk or intermediate risk based on the Oncotype DX, with the HER2-DX, you can also identify the patients probably once it becomes mass available, and with the prospective trials. These are all retrospective trials, prospective trials, and if they did it in ISMO, it was with the hormone therapy in her ear. That means no chemotherapy was given, trastuzumab plus hormone therapy was given in that subgroup, and they tried it there. Any comments?
Sir, can I add one thing?
Yes, please.
So I read through some of these things you said. On the other hand, we are saying that HER2 0 and 1 non-expressing should be given at TDXD. So on the one hand, we are saying that if the patient is not showing any HER2 by IHC, should be using a TDXD because it is responding. There is some low level of expression in most of the cells. So we are trying to imply that you should be giving probably everybody an anti-HER2 therapy. And the other hand, we are trying to say that you should de-escalate the anti-HER2 therapy.
Okay, so
so there is a
we are all learning. Yes, there is some comment from the audience. Yeah, you can add meanwhile. I will just have a look.
Just to know about from the panelist regarding talking about the early breast disease, DCIS with any HER2 positivity, do you use trastuzumab, anything like that? Because there are certain trials going on. Any experiences, sir?
I'm sorry, I didn't hear. I was just looking.
So no, sir. Regarding DCIS with the HER2 positivity, using about trastuzumab, any experiences?
No. I mean the only invasive, not in DCIS.
But still, there are trials running with that.
But I mean, there is no recommendation that you should use
They say there is a lot of false positivity if you do HER2 on a DCIS component.
Yeah.
So if somebody has written HER2 positivity and there is a predominantly DCIS tumor, you should be very careful that asking your pathologist to redo it maybe on the invasive component, because they just write it that way.
Actually, it is recommended not to even test for HER2 in DCIS. So just for ER/PR. I mean, even progesterone you should not be testing, just ER. So the question is, it doesn't arise at all.
So there are two questions from the audience, and one is probably been answered already. Clipping at the time of upfront diagnosis. I mean, you can do it if you want, but you can do it even afterwards. Dr. Shivaram has already answered that. And the other question is from Dr. Sweta Agarwal, and she's asking, do you see breast cancer in pediatric population? Does it happen too? What is your youngest?
Adolescent, yes. The youngest, when I was a resident at Cancer Institute at 13, youngest in practice is 15. So these are just outliers and just for the rarity of it. But in essence, it's a disease of adults.
Okay. I could put my youngest as 21 for the invasive, and malignant phylloids as 18. So, Ashok, you want to add something?
Youngest at 18.
18, invasive breast cancer. So it is there, not below 15 as pediatric population, but if you take 18 as a cutoff, then maybe borderline you may get some cases. Very rarely you can say that, very rarely. Smriti, you want to add? Yeah.
Low HER2 is actually +1.
It's not zero. It's not zero.
+1, +2.
Yeah, +1, +2. Maybe as you fish negative. as we all evolve with the technologies, in the era where I just mentioned that when we were resident, even there was a data to say that patients who with ER negative also respond to tamoxifen, 30% of the patient. But that time the technology for deciding ER estimation was also, it has to be done on the fresh tissue. It was not available like what we are doing right now. So once the technology gets established, probably all these issues will get resolved on their own. This study has been, this slide has been already shown that if you use trastuzumab upfront for a period of 1 year based on these various trials, B31 and HERA trial, and they have shown that the patients overall survival, if you see 8 out of the 10 women will do much better when you give the 1 year of the trastuzumab. BCR006 is also same. So if you see the delta in between the two curves is around 7 to 8%. That is that's very important as far as the trastuzumab is concerned. And these are the short trials, as I mentioned to you, and the HER2-DX was done in the short HER. This is the lower one, 9 weeks versus the 12 months. Even in the 9 weeks also, as they showed that if you are low risk, probably you can de-escalate. 9 weeks is also sufficient to get a good 97% overall survival based on the data. I couldn't get this slide. I would have shown that. So everybody in the audience also agrees for 1 year, or again, as just Chetan mentioned, Nilesh also mentioned that short for the low risk, probably you can go ahead and do the 6 months. But 1 year has been the, I would say that the standard of care. Regarding toxicity, so let me ask Kiran, how many of your patients whom you are treated with the trastuzumab have got the cardiac toxicity? Then I will come to the other toxicities.
No cardiac toxicity seen.
No cardiac toxicity seen. Okay, Abhishek.
50% of the patients do develop cardiac toxicity, especially if once we are using the dual HER2.
Okay.
So at least 2 to 5% patients do have cardiac toxicity, especially if you're treating elderly patients, like the one we are 65 and she has some comorbidity. So you have to be very careful. Our patient there's no comorbidities, but if there are a couple of comorbidities, so the risk of cardiac toxicity increases significantly.
Dr. Rajesh, this patient is, I didn't mention the side. If suppose she had a left-sided 65-year-old receiving the dual, you are giving radiation on the left side.
Of course.
What's the incidence of having the...
So actually, most of the time what we try to do is nowadays we are practicing DIBH, that is the deep inspiration breath holding technique, where you can reduce the toxicity of the lung and the heart very much. It's been only 3 to 4 gray of the total dose that will be received by the heart, and it can be very much meticulously managed to control the heart dose of the heart rate with the radiation. So it's not a contraindication with the radiation. So most of the time it's been.
So what's the incidence of cardiotoxicity because of radiation on the left side?
So usually I can't say that, because most of the time it has been a patient has been exposed to anthracyclines before the patient comes to the radiation. So that also been a contributing factor. Apart from that, patient, if the patient has been with comorbidities, especially with CVD or a kind of hypertension patients, they may sometimes land up. It's very much less. And almost we have got only lesser than 1% of patients who land up with cardiotoxicity during the treatment with radiations.
Okay, so...
But I cannot blame it because of its radiation or because of the prior exposure.
So you are not accepting that radiation will cause cardiotoxicity?
Nowadays, so why? Because the technology has been so developed, and we have been using a fast technique also. It's been very hyperfractionated, and the lesser dose to that with the VMAT technique, still more you have been lessening the dose rate to the heart. So previously, when using a 3D CRT, then it's fine enough to just treat the end mass of the whole chest wall. But nowadays, it's not happening. So
what about the pulmonary fibrosis?
Pulmonary fibrosis, yes, they do occur, but it's also still more less than that. Because previously, what happens is we do have a two isocentric technique, like treating the supraclavicular region separately and along with the axilla, and treating the chest wall. So during that area where there may be a high toxicity dose, there is a combined, baseline dose may be increased at that area where they contribute towards the this kind of a pulmonary fibrosis, like radiation-induced fibrosis. So nowadays it's not happening because we have been using the technique the BMAT or kind of IMRT, where that's very much reduced and the homogeneity of the dosage can be possible with the chest wall as well as the axilla. So it's not happening actually. So.
Okay. Any comments from the audience? If somebody wants to comment, or from the other panel members?
No, sir.
Regarding the toxicity. Okay.
I won't get into an argument with you.
No. It's not argument. So you can have scientific discussion. We are over here to discuss. Yes, we can say that there is a cardiotoxicity with the anthracycline. Yes, we also say that there is a cardiotoxicity with the anti-HER2 therapies. With the anti-HER2 therapy, it is reversible. I have seen in my practice that there has been decrease in the ejection fraction. Most of the time, it is said that it returns back. But in 2 of my patients, it has not returned back. It has remained there, and I had to defer giving the further trastuzumab. I think, yeah, Ashok, you want to add?
How long do you wait before somebody gets a cardiotoxicity, doesn't recover over the next 3 months?
So
still time left for the treatment.
That is exactly happened with my patients, 2 patients. So it was more than 3 months. I just stopped trastuzumab. I said, I don't know, there is no data to suggest beyond 1 month is standard that we can all wait, but beyond 3 months, I don't have any data. So I said better not to. Unfortunately, now 5 years, these patients are doing well. So probably we did the right thing rather than making them to have cardiac problems. Abhishek, you want to add something?
So I agreed what you did. Clinically, it would be very difficult to restart somebody knowing that he has not recovered from a cardiac toxicity. Or maybe even he had a cardiac toxicity. I don't know how you restart that antibody again. Somebody had a LV dysfunction to a trastuzumab and he recovers.
Recovery is delayed.
Delayed recovery. 1 month is fine. I mean, we have all done that. It has recovered back after 1 month and we started. Nothing happened after that.
So I don't think there will be data to suggest we could restart again. Since the patient has developed LV dysfunction once to trastuzumab. Most of these patients were taken out of the trial.
No,
whatever data we have.
The cardiotoxicity happening because of the trastuzumab or the pertuzumab is a reversible cardiotoxicity. It reverses practically within a month, and you can restart beyond that. So we have restarted. In my practice, we have done it, and there is no second, I would say, that decrease in the left ventricular ejection fraction.
What kind of a cardiotoxicity you have been experiencing, sir?
Rejection, LVF reduction. So we usually look at less than 10%. So if it was some 60, then 54 ejection fraction like that. Below that, then I stop it. Again, I try to see that the patient goes to same cardiologist who is doing, because again, there are interpersonal variations in the reporting. It is not subjective, it's an objective. So that's where also
the role for GLS, the global longitudinal strain,
that
is emerging in predicting the
cardiotoxicity. Okay, the other toxicity what we also get from the surgery is the lymphedema. So how do you somebody who has got a huge lymphedema, so many patients, they come and ask, especially like this patient, like N2 radiation given, surgery done, the lymphedema is bound to happen. Whether the grade may vary, some people may have little, somebody has more. So how do you handle that?
So the best strategy will be to prevent, because in dealing with an N2 disease, I know that I have the potential to, my hands can create lymphedema. So I'll be very wary of sticking to my fields. Lymphedema in general happens as a surgical complication. The surgeon has to take responsibility. Unlike radiation, it's the surgeon who causes. So stick to where you should dissect. Do not get carried away and go outside your fields of dissection. So that is the mantra that we have. If everybody diligently follows, as a surgeon, I would take ownership of that, and your rates of lymphedema have to be lesser. These are the cases where your skill is put to test, and it's a matter. Prevention is better.
Okay, prevention is better for everybody. And I
just add to one more point, sir. You are very generous, sir, really, because most of the time what happens is lymphedema happens only after 3 to 4 months. By the time they start with radiation, so it's been blamed with the radiation actually. Thank you for that.
do you accept that? No.
And it's not an immediate kind of a complication. They come up with
okay.
Meet the surgeon for that.
So I think our time is over. So I mean, the organizers are saying that we have to wind up. And thank you very much for your lively discussion. If any questions in the audience, then otherwise I would say thank you very much for everybody. Thank you.
Thank you. Thank you for pulling me in. Thank you, Dr. Basade, for that wonderful moderation and keeping the discussion to the practical points which are day to day in the clinical practice. We move on to the next session, which is a case-based panel discussion in early TNBC. I have the privilege to invite Dr. Vamshi Krishna. He is the Director and Head Medical Oncology and Hematology, Institute of Oncology, AIG Hospital at Hyderabad. Over to you, Vamshi.
Thank you, sir, and good morning, everyone. It's a pleasure being here as always, and on an interesting topic. So, a slight modification, I guess. I'll be just going through the case and discussing through and through. So for next 20-25 minutes, we can do it. If I could have my panelists, Dr. Subhash Agre, Dr. Sachin Jain. Dr. Sachin is here. Dr. Sushant Mittal, I saw him sitting. Yeah, Dr. Chetan Deshmukh. So it's a very straightforward case which I will try and present, and we will discuss what are the things to do in an early TNBC, right? For some reason, there's a different case put up. If you can just have my slides, please. This is case scenario 3, but I would want case scenario only one case of mine. So while the case is being loaded, if I can just start with the panel, Dr. Subhash, what's your definition of an early TNBC? That's what my topic is, early TNBC. So how do you define an early TNBC? How early is early?
So early TNBC would be T1 lesion, node negative disease, that would be defined as early TNBC.
Okay. So anything above T2 becomes a locally advanced, yes, if that's the case. So I think if that is the case, there's nothing much left for us to discuss, because T1, I don't think there's anything to discuss. Dr. Chetan?
I won't call T2 as locally advanced by definition. By definition, it is T3 or N2
T4
or whatever. Yeah, T3
okay,
and above and all that.
Okay.
But if the indication to give neoadjuvant chemotherapy may change,
okay,
that is
okay. So at least I think for the purpose of this discussion, let's keep it at wherever you want to give NACT, which is an operable breast cancer. Let's call that a TNBC.
So
maybe
then,
you know that.
Then it's going to be T1N0.
Operable where you can give chemo, where you can give NACT. Where you would want to give
then you would include T2
and probably
T2 and
N plus
N1 clinically.
Very good. Right. I think that's what, let's keep it for this definition, because if we start going to T1, this discussion will not really start after that. Great. So next slide, please. I have here. Okay. How does this work here? Where do I point it? Point it where? There. It's not working if I point it there. I think it's easier to just slide change from, yeah, great. So 45-year-old lady, she was the director of her own company. Her husband also is pretty well off. Postmenopausal, no family history, presented with a small lump in the breast. Evaluated on examination, 3 centimeter lump. Breast to lump ratio is adequate, more than enough to do a lumpectomy. Okay, so that indication I'm removing from here. Next slide. She was evaluated with a biopsy and a scan. The biopsy shows, can I have the next slide? Okay, now it's working. So the mammogram showed a BIRADS 4 lesion, and the biopsy showed infiltrating ductal carcinoma, ER, PR, HER2 negative, AR also negative. Then we got a PET scan done, and it showed only a lesion in the breast, 2.2 into 2.2 centimeter, and node negative. Ultrasound of the axilla also negative. So we have a T2N0 postmenopausal, highly educated, wants and efforts for all therapy, right? So Dr. Chetan, this patient, where would you put?
So she's tumor is more than 2 centimeter. By definition, this lady can go in for neoadjuvant chemotherapy.
Okay. Dr. Subhash, does the decision to give neoadjuvant depend more on the age or the size, or what's your defining thing here? Or all TNBCs 2 centimeter plus?
So basically it would depend upon the operability as well, along with the other factors. Say with the more or with the TNBC, this kind of lesion, it would be better to go ahead with the NACT only.
Okay. Dr. Sachin, agreed? NACT in view of more than 2 centimeter TNBC.
Practically, I would say that in routine, these patients are going first for surgery, even for the breast conservative surgery. Then generally we see these patients for adjuvant chemotherapy.
Okay. So practically, this is sometimes it goes to a surgeon. Depends on where they go, rather than the signs. Okay, Sushant.
Yeah, I would agree with Dr. Sachin that if it goes to the surgeon, majority of them undergo the surgery first.
Okay.
But I will also like to have the BRCA report in her.
BRCA report before starting any therapy, or you would want it during the course of therapy?
During the course
No,
of
that's okay. We'll come to the BRCA. I have slides on that. Can I have a show of hands in the audience? How many would send this for NACT given a choice? Let's not talk of where the surgeons go. Out of choice, how many would want okay? So I can see an enthusiastic show of hands. I think almost all medical oncologists especially would want to push this patient for a NACT. So I think the cutoff is 2 centimeter and above, if the panel agrees with that. 2 centimeter above or any node positive. Very good. So that I think is clarified that everybody wants an NACT, not a surgery. If NACT, why NACT? Sushant, you said NACT I would give. Why NACT? Are you looking for an overall survival advantage? Are you seeing the PFS advantage? Or are you going with a PAT-CR?
I'm going with the PAT-CR.
Okay. With the intent of what? What does
With the
PAT-CR?
intent of that, probably the OS will also improve. That's a surrogate marker.
Surrogate marker for it. Yes. Dr. Sachin, do you agree with this?
Yes, in the triple negative breast cancer, specifically the pathological CR is very important, and it is directly related to the oral survival.
Directly, is there a convincing evidence of this? I mean, I'm just asking because there are studies which are on this way, that way.
Yeah, as we said in the NCCN, they also recommended the in the TNBC, pathological CR is related to the OS as compared to the ERPR positive or in the triple positive breast cancer.
Dr. Subhash, do you agree with this?
Yes, the intent would be definitely to see for the PAT-CR, and if it is not, then we can modify our treatment option based upon the results.
Dr. Chetan, a more senior voice, I would say, who has seen it all along this so many years. If this was a 68-year-old lady, you know, would you still say I want my PAT-CR?
So I was actually going to talk about PAT-CR in a different way.
That please.
When we give chemotherapy, when we give neoadjuvant chemotherapy, and we say that we have X number of people going for PAT-CR, we are probably just biologically selecting the better ones. I don't think that our therapy is actually going to make a lot of difference, because eventually no PAT-CR, then you put them on something else, put them on maintenance, something or the other is going to happen, and we are just going to find out who is biologically better and who is biologically worse. Having said that, this lady, she's 45. I would definitely, my goal right now is going to be PAT-CR, because that is the only goal I have right now. I don't have any other goals to go by. And I'm hoping that if I achieve a PAT-CR, my OS is going to be better, and her post-surgery treatment is not required. If it's a 68-year-old lady, then I would probably just look at her choice. If she wants breast conserving surgery, if this is the situation that the breast to tumor ratio is favorable, I don't know whether she'll be able to tolerate full neoadjuvant chemotherapy or not. At that point of time, the discussion is going to be different.
Perfect. So I think that was what I wanted to bring around, because Dr. Sushant, again, the same question, does increasing the PAT-CR, like Dr. Chetan said, you're always going to have a 10% population which doesn't do well. You're going to have a 30% population, even in your non-PAT-CR, who are going to be cured. So are you just taking this chunk of curable patients and giving them more PAT-CR by increasing your chemo? I mean, that's the question which I think surgeons ask with some justification, where every small tumor is pushed for NACT. So your thoughts on this?
So my thought is just like, if you do good in pre-boards, probably you could do good in boards also. So if the PAT-CR is there, probably the survival would be there. But yes, as Dr. Chetan said, we are selecting the population. We are just segregating who is in PAT-CR. So if the surgeon asks me, I don't have any robust data to say that, yes, the survival benefit is there.
Dr. Basare, sir. So a very nice analogy. Pre-board mein acha kiya to parents will sleep nicely for the next 2 months. Yes, Dr. Basare.
So we have achieved somewhere around 40% PAT-CR with the sequential chemotherapy, and we know that the survival is what now, not in this patient, but you ask question of PAT-CR. In node positive, I will give a corollary. With the advent of the immunotherapy, when the immunotherapy got added, the PAT-CR went up to 61%. Now this 40 to 60%, and now the impact of that also has been translated into the overall survival.
EFS, sir. No OS so far. EFS.
Yeah, I mean, you can.
Clear EFS.
Yeah, EFS, you can say that. Okay, at present, at least EFS, because it's early data. That means that improving PAT-CR is improving the survival.
Fair enough. So this is, again, there are several meta-analyses. In fact, in our WhatsApp group today, somebody has posted one meta-analysis which said that there is no overall survival benefit. There are several other meta-analyses which are showing the overall survival benefit. This is just one of them, which shows you a hazard ratio almost 0.28 for TNBC when you give NACT. And based on these several data, PAT-CR is actually accepted as an endpoint for accelerated approval by FDA. I mean, this is not an absolute thing, this is not a written in stone thing, but it just gives an indication that probably at this point PAT-CR should be accepted. So let's assume this is all giving PAT-CR NACT. Dr. Chetan, starting with you, role of immunotherapy now in NACT.
Yeah, the data looks promising. It has, and addition of, though I have done it only once, but there were no increased toxicity.
Okay.
And the patient really did well. So
so
definitely attractive at this point of time.
So which patients would you like to give it to? How do you select these patients?
So I would give it to triple negatives where
All
I'm
triple
planning.
negatives.
Yes, all
Okay.
triple negatives.
Okay, Dr. Subhash, agreed?
Yes,
Yeah.
but the cost and other factors.
Cost,
need
this
to
is
be-
my patient is very affordable. Okay, this patient is one who came and said, I want a Mayo opinion. Do you want me to fly to MD Anderson for a surgery? So, that kind of patient, they can afford. So my question more is, would you like a PDL1 here? Because, in metastatic, we know that only in PDL1 positive it works. In NACT, it seems to work everywhere. So you would want no PDL1, you would give it irrespective of everybody. Excellent. Which immunotherapy would you like to give? That's the next question.
So the pembrolizumab would be.
Only pembrolizumab. Dr. Sachin, you agree?
Yeah,
Okay,
exactly.
so this is a slide I have borrowed from Dr. PP Sahu. He very generously provided it to me. So if it's a busy slide, but it basically shows you all the immunotherapy trials. So you have I-SPY 2 with only pembrolizumab, given only as neoadjuvant, which increases PAT-CR. You have the Keynote 522, which is what everyone is talking about, where you have neoadjuvant and adjuvant. You have the durvalumab trial and the Atizo trials. Now, Atizo trial did not really do great. The Durva trial improved PAT-CR only marginally, but it gives you a 3-year survival advantage, which is not seen with others. This is the data, what is there with all the IOs. So with this data, what's our thought? Would you want to give IO still? You're convinced of the data, Dr. Sushant, or you would want to possibly wait for a long-term OS data?
So it's a very early data. It depends from patient to patient. Since your patient is affording, I would definitely use Pembro in this patient.
Fair enough.
But I won't push patients to use Pembro.
All right. Okay. So Pembro as such seems to be having the data in terms of PAT-CR. Again, if you believe in the PAT-CR, you're not wrong in giving it. Sir,
What about the node positive versus node negative?
can any of the panelists take that? So actually the trial has shown benefit in all subgroups. The trial showed benefit in all subgroups. Logically, you would possibly want to give it more in the node positive.
522 was, I think, node positive. High
So
risk node.
it included everything, sir. It included T2 also. T2 to T4.
T2 to T4, node
And,
positive.
Showing stage 2 and 3. It's written.
2 and 3. 2 and 3 includes T2 and 0 also. It included that. Small subset, I don't remember the exact numbers, but it included. It was only 10% probably, but it included it. Okay, so favorite question, long-lasting question, which all medical oncologists talk. I think 15 years we have been discussing this. Platinum. Any consensus? Sushant, agreed you give platinum to all TNBCs or?
I don't give, but if the patient, as Dr. Chetan was mentioning before that, if the patient says the lump is not dissolving, it's not reducing, then I might add.
Okay, so clinical-based decision.
Clinical based
All right.
decision.
Nothing wrong in that, Dr. Sachin?
Some data is BRCA1 positive, then we can also add the carboplatin in TNBC.
Okay, you would want to use platinums only for the BRCA. Actually, there's some data saying that it doesn't work in that subset. So, it's a mixed subset. Basically, where you can't use a PARP in order to use platinum and mixed data. Dr. Chetan?
I agree that if the lump is not reducing as much as we expect after, say, 1/3 of the chemotherapy is over. But about BRCA, I have burned my fingers. BRCA positive people sometimes react very weirdly to platinums. Their metabolism of platinum is very scary. And then they come up with some myriad toxicities which are not expected in this kind of a population. We have a 45-year-old lady who is obviously extremely well educated and very well off. You would rather go by the standard therapy rather than doing something adventurous.
Dr. Subhash, adding carboplatin or cisplatin, because again, some of the trials included cis also. The trials, the keynote actually included carboplatin. The Atezo and Durva did not include carboplatin. So that's one of the differentiators, how to distinguish between the two. Practice, do you add, don't add?
So if you want to consider, then the carboplatin becomes easier an option just to consider, because there is no data head-to-head data to compare of, but just for the carboplatin would be a more convenient option.
Okay. The reason again, we have the veliparib trial, which actually showed that veliparib didn't add anything, but carboplatin added to the benefit. So that's the reason why, especially it's a BRCA positive negative, again, it's a mixed data. But if you're giving an ICI or an immune checkpoint, would you add platinums? Or would you hesitate in that case? So again, it's a gray area, I guess. Again, so that's why there's no answer.
Yeah, Vamshi, there are a lot many. I wanted to actually stop when somebody said it is not responding, response is sluggish, and we would like to go with the standard of care. The standard of care in early breast cancer is surgery. We are trying to form new standards of care and trying to extrapolate the adjuvant data for this. So that is a reminder, one. And especially when the response is sluggish. So definitely that is a surgical disease, and especially in all this. And then if it is a BRCA, we are thinking of platinums and other discussion. There has to be a discussion on mastectomy. Bilateral mastectomy is also. Angelina Jolie should not be forgotten that early.
Okay, so the first part of the thing, we are not relying extrapolating from adjuvant data. We are looking at neoadjuvant data. That's one thing we have to understand. We are no longer extrapolating. We have phase 3 trials in neoadjuvant now, sir.
No, there has been always surgeons saying that, if you give chemotherapy, what happens, then the disease progresses, is not responding. So NSPB B18 has already ruled out that. B18 has 3 arms, give complete chemo, then surgery, and then radiation, do sandwich or surgery, and then chemotherapy. All 3 arms did well, same survival. So there is no benefit of doing surgery in between.
That arm, there was a practice thing. Okay, Shivram, I think we are getting distracted into the surgery part.
There are 3 arms. Without taking much time or taking the discussion away, I'll just bring it to the point. So the trial data will look different because we are looking, Dr. Chetan was making that point. We are trying to apply the data to the individual patient. So overall numbers may not look different. It is just a matter of rearranging these numbers and different subsets in different manners. But for the individual patient, I would still like to consider that there is a definite role for surgery, especially if the response is sluggish.
Anyway, so for this patient, we had a lot of discussion, to be honest, as can be expected. And luckily, she had a history of active rheumatoid arthritis and active autoimmune conditions. And she was on tofacitinib. I learned that there is a medicine called like this in this used for autoimmune stuff. Essentially, she had so much autoimmune that all of us are very happy to say that, okay, no pembrolizumab for you. So we were relaxed. Now, in this patient, very interestingly, what all of you are talking about, patient was started on paclitaxel and 3-weekly carboplatin. 3 cycles, no clinical response. Dr. Chetan, this was exactly the same thing what happened. So in this patient, after 3 cycles, no clinical response, what do? So we stick to the medical oncology side, not as Sivaraman has said that you go ahead and do a surgery. We said, let's still go and try more chemo. So we gave 4 cycles of anthracycline and cyclophosphamide. No clinical response again. So this happens. Dr. Chetan, this is what happened. You're right. This happens. Luckily, I didn't get the toxicity, but this happens. So after that, patient went up for a surgery. And in this segment, before surgery, anyone wants to intensify and give more chemotherapy, or you're happy with the 4 drugs you have used? Okay, so Shivaram, we are all happy with 4 drugs. We don't want to give 5th and 6th. But there are trials which have shown that if you add capstabine, it doesn't help much. Sir?
One of the GPAR trials has clearly shown that non-responding patients, even if there was a randomization to, I think, vinorelbine in that. And it clearly showed non-responders are non-responders, whatever you do.
Right, perfect. So this patient underwent a surgery. So she underwent a lumpectomy, initially SLNB done. Again, let's not get into controversy of should you do it after NACT or not, followed by an axillary dissection, though nodes are negative on SLN. She underwent a full axillary dissection, got an implant placed. Flap was planned, but flap could not take because of the vessels were thrombosed, so flap could not take, so implant was put. Okay, and after this, the histopathology report showed a 3 centimeter lesion, lump, no response at all to any chemotherapy. So that was the response shown at that point of time. So at this point, let's forget this patient, but in general, starting from Sushant, adjuvant therapy with IO. Would you want to give IO as an adjuvant if not given in neoadjuvant? Would you like to continue it beyond neoadjuvant if you have used in the neoadjuvant?
I would not give in adjuvant if I have not used in neoadjuvant.
Very good. So, Dr. Sachin, your thoughts? Would you use it in the adjuvant if you have not, if you have used it in the neoadjuvant, because this is again a very interesting paper which came this year from the ESMO, I think ASCO or ESMO, where they looked at the residual cancer burden in Keynote and found that RCB 0, which means there's no burden, and in RCB 1, there's no benefit of adding pembrolizumab in adjuvant. The benefit of adjuvant pembrolizumab was mostly seen in those patients who did not have a residual cancer burden of 0 or 1. So this is the data. You can see by category, the benefit is very less. So would you add immunotherapy? And coming back to the first thing, identifying the subset which will benefit from more treatment. That's what you're doing if you give neoadjuvant. So your thoughts on this paper?
As there is no response to chemotherapy, and sir told that if no response to therapy means there will be no response, and still somebody wants to use in this patient IO. So in my opinion, we should go for PDL1 like TMB, and then we decide that it will be better.
PDL1 uniformly shown to be non-predictive for TNBC in the neoadjuvant and adjuvant. Yeah. Only in metastatic there is some benefit. But fair enough. And TMB is a whole story. I don't want to get into it. Dr. Subhash, your thoughts again with this RCB? Is this something that we should start looking at now?
Yes, the data looks promising. We should start looking at, because this would be an area where we would be facing on a day-to-day basis. So maybe we need to check into it and apply accordingly.
Dr. Chetan, are we now coming to an era where IO can be used and then you decide whether you want to give IO later based on this fact?
So this lady would fall into RCB 2 or 3. Whatever.
3. She is 3 or 4 actually.
3.
There's no response.
So whatever benefit is seen is only in that subtype. So if she is okay,
anyway,
and
this
I assume that autoimmunity business is sorted
this
out.
Patient we could not give any this,
yeah,
right? So just last 2 points. Capstabine, would you add or not? Everyone is vigorously shaking.
Yes.
Uniform consensus now. Only for those who don't get PAT-CR, or would you do it for all TNBC?
Those who don't get PAT-CR.
Who don't get PAT. What about node positive? The Createx also showed some benefit in that node positive subset. Very good. So again, I think there's uniformity now. You would give Capstabine. The Createx used it based on the PAT-CR. The SYUCC used it for everyone. But by and large, I think all of us are comfortable using Capstabine as a drug later on if you don't get a PAT-CR in a TNBC, or if you have very high nodal burden. Probably that's where you would have to use. Our patient was BRCA negative. We did start on Capstabine. She has completed around five months so far. And 5 months so far, she's good. I don't know how long she'll be good, but yeah, one question we can take.
Since it's a bad case, she never responded. Capstabine for 8 cycles or continuous capstabine?
We are planning for 6 months for whatever it is worth.
So what would be the ideal thing to do in such a case? I'm not asking.
I don't know the answer to it. I really don't know the answer. Yes.
Once the one is non-responding, what should be the intent? Curative or palliative, and how we should counsel?
It is a special group of patients whom we call prayer kind of category. To be honest, seriously though, we don't know the answer. We don't know why it has not responded. We have not yet done a genomic or transcriptomic analysis with all the genes and then find out a pathway which is blocked and stuff like that, because we don't know if it works. That might probably give us an indicator why this patient is not responding, but that's all the answer that I have as of now. We are giving it because the trials have shown that there is some benefit. Final point, Olympia, Dr. Chetan, would you agree if it was a BRCA positive, confident of giving Olympia or PARP, and would you give it in all patients?
For this lady, she's not responded to anything.
She's negative BRCA. If she was positive,
she's negative. But if she would have been positive, she's not responded to our conventional chemotherapy. I may give it a thought.
Okay. Those who have responded, would you still give it, or would you still not give it in those patients? Panelist? Okay. Great. So this is the Olympia. Again, a trial which seems to show some benefit. We have talked about this. So to summarize, I would say early TNBC, we have increased PAT-CR, showing improved EFS and OS. There are some controversial topic, but it's there. Carboplatin, plus minus, the data is jury is out, helps us decide on giving adjuvant Capstabine. That for me is very, very important. Immunotherapy improves PAT-CR, possibly IDFS, possibly EFS down the line. RCB is interesting. It can be used as a marker for adjuvant therapy. Capstabine, I think, is now acceptable for everybody who doesn't have a PAT-CR or is node positive. So if everyone agrees with this, I think I'll close the session here.
One question we are always discussing about adjuvant and neoadjuvant chemotherapy, and we use 4SC, 4 Paclitaxel dose dense, and second option is 4SC, then weekly Paclitaxel. The third, that is a docetaxel and endoxan with only 4 cycles.
You can use that.
Any personal experience of anybody?
Only docetaxel and endoxan.
Yeah,
without using cycles. Other things.
Yeah,
I have not done it. I have not done it. I don't know if anyone is doing it.
Because according to NCCN, it is also in category 1 recommendation. So anybody has used
for the neoadjuvant, sir?
For both adjuvant as well as neoadjuvant.
One important is that it should be node negative disease. then TC can be used. Node positive, that means high risk patients, you have to use the sequential.
Okay, thank you, sir. Thank you, everyone.
Thank you, Vamshi, and such a wonderful piece of discussion. And thanks to all the moderators and the panelists till now, so much revision of the topics in such a short time. I think that's a great learning out of it. So I have now the privilege of inviting Dr. Radhe Shyam Naik to take us through the management of metastatic HER2 positive and triple negative breast cancer. We heard about the early HER2 and the metastatic triple negative. So Radhe Shyam is going to take us through that. He heads the medical oncology and hematology bone marrow transplant team at the Samprada Cancer Center, Healthcare Global, Bangalore. Over to you.
Good afternoon, everybody. I'm thankful to Viatris for giving me this opportunity. I have to be short because I have to catch a flight at 3 o'clock. So it has to be a very short presentation. Unfortunately, it is metastatic disease in HER2 positive and triple negative, but I want to rush through. And if there is time constraint, please indicate that so that I can stop as quickly as possible. How many minutes I have? Till 1. So about 20 minutes. Okay. Yeah. Can I have the first slide, please? Sorry? Oh, here. Okay. Okay, so there are several drugs which are approved for metastatic disease. Fortunately, in metastatic HER2 positive cancer, you have the privilege of knowing whether it is working or not in real time. Tumor shrinkage and not shrinking. And we have several antibodies and several TKIs which have come. And each one has come because the earlier drug developed some resistance. And if you look at the NCCN guideline, of course, all the drugs are, you can do anything you want and get away with it actually. You can combine any chemotherapy with any of the anti-HER2 drugs, you still will be all right actually in majority of the cases. But there are some newer concepts in HER2 positive breast cancer. Of course, this is showing trastuzumab here, pertuzumab at a different level. Then HER3. Now HER3 is becoming a very important molecule because there are cancers where HER3 is getting more expressed, and one of the resistance mechanism for anti-HER2 therapy is overexpression of HER3. And in ER positive patients, HER3 is becoming another very important marker. And then, of course, there are intracellular markers, pathways, which can develop resistance to HER2 by the mutation of that. And if you look at the breast cancer in general, so 20% are the true HER2 positive, which is 3+ or FISH positive. 25% are true HER2 negative, that is 0. And there is 55% who are low HER2 positivity. And now triple negative disease and ER positive disease is getting complicated because many of them are low HER2 positive patients. And this is another way of looking at the resistance mechanisms. You have got IGF, VGFR, MET, and there is interconnection between everything. VGFR, MET, HER1, 2, 4, and even lower down, here MEC. So it's getting much more complicated. Okay. So now we know that it is not enough to see whether patient is HER2 positive in metastatic disease. You need to know whether it is HER3 positive, whether it is HER2 is 1+, 2+, or 3+, whether the tumor infiltrating lymphocytes are there or not, PD-L1 is expressed or not, EGFR and HER3, and whether PI3K, AKT, mTOR pathway is mutated, because this is one of the resistance mechanisms. and whether there is HER2 mutation, and even in HER2 whether it heterogeneously positive or homogeneously positive. So if in the tumor itself, if HER2 is homogeneously positive, then the patient will do well with anti-HER2 therapy, and of course ER/PR positivity. So this is the co-expression of EGFR. Certain patients EGFR gets increased, and so the resistance to Herceptin. Okay. And then came the, sorry, I think, yeah. So this is the HER2 claim trial where the 34% reduction in the death in the usage of Herceptin. And this is the second reason how pertuzumab came, because of HER3 expression and HER2 HER3 expression. The drug available earlier was only pertuzumab, and this is the trial in metastatic breast cancer, combination of pertuzumab, trastuzumab, and docetaxel, showing that there is an improved survival. Then the next drug which has come up in metastatic breast cancer is TDM1, and the specialty is that it directly takes the chemotherapy into the cell, and hence it has shown improvement over capecitabine lapatinib combination in this trial with the overall survival benefit. I think this is biocarmazine. This drug, there is in the FC portion of the antibody, there is a tweaking, and it improves the immunity. So when the tumor infiltrating lymphocytes are high, and you use, instead of trastuzumab, you use biocarmazine, then you get a better response. And there is a concept called HER2 enrichment in HER2 positive breast cancer. If you have a HER2 positive in the IHC, but you also have an increased HER2 mRNA levels, then there will be a super response to anti-HER2 therapy. And this helps us to know whether we can avoid chemotherapy in this situation, at least in addition to the anti-HER2 therapy. And you can probably use 2 or 3 anti-HER2 combinations and probably control the disease for a long-term survival in this metastatic HER2 positive breast cancers. So this is one of the very important things for us to recognize, which we do not routinely clinically do. And there is a concept of heterogeneity of HER2, and it has been seen that if there is a scattered or mosaic and clustered type, where there is a difference in the two ends of the primary tumor, for example, one tumor you take biopsy from 2 sides, and if there is more than 50% difference in HER2 concentration, then it is called heterogeneous HER2 positivity, and response rates will be much less than the homogeneous positivity. Then we also looked at, this is one small research we are doing in HCG. We are looking at the percentage of TIL and looking at the response to the anti-HER2 therapy. And we, in that small study, we have seen that as when the TILs, tumor infiltrating lymphocytes, are sparse, or what we call as cold tumor, the anti-HER2 efficacy comes down in the tumor. So here again, TNBC is more appropriate for immunotherapy because the TMB, tumor mutation burden, is higher than any other population. But HER2 also, there is some evidence now that with the better anti-HER2 therapy, we can combine immunotherapy along with that. So this is the immunotherapy in HER2 tumors. At least in experimental models, there has been, especially with the newer TDXD anti-HER2 therapies, with anti-PD-L1, there has been increased efficacy. There is a concept which I found interesting this is in triple negative. 30% of triple negative patients, there may be no HER2 amplification, but there is a HER2, circular HER2, which was positive, which is a pre-translational HER2 gene splice, and there are clinical reports that there is increased HER2 activity, and pertuzumab can be effective in this situation. So because we are discussing with TNBC, sometimes when you don't have any treatment for TNBC, you can look for this this gene, and this is actually a RNA. Then you may be able to treat these patients. And then, of course, we have got HER2 low positivity, and they are more biologically similar to HER2 triple plus than to HER2 zero. So that is the concept. They have larger tumors, higher grades, higher Ki67, and increased nodal status for these patients. And this is that crosstalk. Okay, so this is a concept which there are drugs now called zenocutuzumab, which is both an HER2 blocker and a HER3 blocker. It has got two arms, that molecule. One arm blocks HER2, another arm blocks HER3, and this is useful when there is resistance to trastuzumab. And of course, all of us know about the low HER2 and trastuzumab's deruxtecan. And when Herceptin fails, deruxtecan can still help because it has got a better payload, and it kills the low anti-HER2 expressing cells better than the other drugs. And okay, this is the response in the yeah. Again, to say that the HER2 positive patients are two groups. Hormone receptor positive and HER2 positive are completely different from HER2 negative and HR negative patients. And you can see that the response rates in several trials are different and much better in the hormone receptor negative HER2 positive patients. And this is some new drugs for HER3 positive MBC. And it is not only expressed in breast cancer, it is also in several other cancers. So of importance to the medical oncologists a lot. And already there are drugs which are available for at least in the advanced clinical research. And this is an anti-HER2 therapy with an attached chemo moiety. So if you look at resistance to Herceptin, it depends on several factors, and one of the factors is the polymorphisms, where the FCR portion gets a particular mutation, and we know that if this particular mutation is there, there is best response to the Herceptin in metastatic breast cancer. And there are now drugs which is called margetuximab, which does that, and you can see that it scores over the trastuzumab. So if you look at the current approach to the metastatic HER2 cancer, we have got taxane, trastuzumab, pertuzumab first line, TDM1 second line, and if you have significant CNS disease, you can use drugs which cross the blood-brain barrier, tucatinib, trastuzumab, capecitabine combination, and then you can go for trastuzumab, deruxtecan. And if there are no CNS metastasis, you use trastuzumab, deruxtecan first, and then maybe tucatinib and all that. And then newer drugs like margetuximab, niratinib, capecitabine can be used in subsequent cycles. So I will skip this and last few slides about triple negative breast cancer. So we know that triple negative breast cancer forms triple negative cancers, BRCA positive cancers, basal cancers form one complicated group. And we have certain chemotherapies, almost all chemotherapies work well in triple negative breast cancer. And this is just to say that triple negative breast cancers are different from other cancers, especially when in metastatic setting. We have seen early triple negative breast cancers don't do that badly. But once they have node positivity or metastasis, they dramatically shift and have a worse prognosis. And this is to show that if you have a triple negative breast cancer, your pathological complete response is 45%, whereas in others it is much less. So it is that is why we always add chemotherapy upfront in this. And do we add carboplatinum to every TNBC? It has been discussed in the early breast cancer, but in metastatic breast cancer, probably we need to add it at some point. And almost all of my TNBC patients will get carboplatinum at some point or the other in a metastatic setting. Maybe upfront, sometimes maybe later. This is about the bevacizumab. I think there was an increase for PFS when it was added to chemotherapy, but because of the cost and because overall survival was not reached in this trial, it was given up as a viable option in USA, but still being used in Europe. And one thing which we don't do and which probably we should strongly try to do is subgrouping the triple negative breast cancer by basal like 1, 2, and this last case which was shown, I think it is something like mesenchymal stem cell or mesenchymal likes triple negative breast cancer, and that is why I think it didn't respond to the chemotherapy at all. This is Embrace erbilin, one of the important drugs. I think we have a very good experience, and we have even published also about the combination of erbilin and capecitabine in some of these resistant triple negative breast cancers, and we have had good responses at least. This I will skip. Of course, PARP inhibitors already has been touched. There are trials which again show overall increase in progression-free survival, but no overall survival. Olympiad study, olaparib and chemotherapy. You can see progression-free survival. The upper curve is olaparib and the lower one is chemotherapy. And you see that overall survival, hardly any difference. And so I think, yeah, immunotherapy, of course, we know that atezolizumab, nab-paclitaxel, and metastatic TNBC, again, response rates were okay, but there was no, unlike early TNBC, I think in metastatic TNBC, immunotherapy has had very disappointing responses and disappointing long-term results. So this is in MSA high patients. You can see that several cancers it has been tried. And last few slides, I think these are several markers which are there expressed on the triple negative cell, and the most important of it is TROP2, which is also expressed in several other cancers. And the antibody sacituzumab govitecan is a very important drug, emerging drug, and it is compared to the treatment of physician's choice. And you can see here that there is a difference of about 5.4 months between the two arms in the overall survival. So this is a good drug. I think probably will come into upfront therapy. This is overall expression by TROP2 expression, and we know that the more the TROP2 expression, more the efficacy of the sacituzumab. So these are the guidelines. I think I don't need to And if you look at the NCCN guideline again, I always wonder about the NCCN guideline. You do anything you want, you will be within the confines of NCCN guideline. So everything is covered there. And I think I want to stop because of lack of time. Thank you very much. Thanks.
Thank you, Dr. Adesham, for taking us through the spectrum of treatments for metastatic HER2 and TNBC setting, and also dwelling on some of the futuristic developments. I have the privilege of inviting Dr. B.K. Smruti to moderate the next session. Dr. Smruti is one of the senior most oncologists, very well known, doesn't need introduction to the oncology fraternity. That's all I would say. Thank you so much.
So I'd like to thank the organizers for giving me this opportunity to have this panel discussion. I would like to call on my panelists, Dr. Matthews, and then Dr. Nilesh Lokeshwar, then Dr. Chandragowda Dadagowda, and Dr. Bharat Bhosle. So I'm not going to be showing you any literature slides because I think everything has been covered. So we're just going to look at clinical scenarios and then see how our esteemed panelists are going to manage this case. So let's look at the clinical scenarios. Why is it not moving? It's not moving. It's not moving. Okay. So now let us look at this first case scenario. Who is a HER2 positive metastatic breast cancer, and it's a 55-year-old woman who had undergone a resection of a 25 millimeter grade 3 invasive ductal cancer, ER/PR negative and HER2 amplified. She was treated with the ACTH regime. She then continued with adjuvant trastuzumab, and 2 years after completing adjuvant trastuzumab therapy, the biopsy confirmed the HER2 positive ER/PR negative metastatic disease in the liver. So now I want to know, first thing is that will you do a rebiopsy or will you directly go for the next treatment? Would you assume?
So this patient has almost had a 2-year interval since completing therapy, and definitely I'd like to do a biopsy to confirm the ER/PR as well as the HER2 positive change. It's unlikely that the ER/PR is really going to change, but the HER2 positive definitely can, and therefore it should be done whenever, in fact, probably at every relapse, and definitely if it is beyond 6 months since the last treatment.
What do you have to say?
Definitely, I would consider redoing a biopsy because I have patients like after 2 years, again, a clonal change has happened.
Yeah. Anybody else wants to do?
I mean, in a HER2 positive setting, doing a rebiopsy, would you change your treatment modality? That's my question here.
So I just want to make a point here. Actually, in the ABC guidelines and all, it's mentioned that you do a rebiopsy, one, to confirm that it is metastasis from breast cancer and nothing else. And the second thing is that if there is a long duration, like 2 years, then you would, like HER2, the discrepancy can be to the tune in HER2 to about 5 to 6%. In ER/PR negative to ER/PR positive, extremely uncommon, but sometimes you can lose the ER/PR positivity. So this is the thing. So what do you have to say?
So I do biopsy for all wherever feasible, unless and until it is a special scenario where the life is endangered. Otherwise, biopsy for all.
But I think, again, I want to bring a point of somebody who is HER2 amplified first. So being a heterogeneous disease, even in part of the segment where you do a biopsy, if that is negative, doesn't mean that you would end up not using an anti-HER2 therapy in them. So that's the point I want to make. Yeah.
So that is again in the guidelines that even if there is a discrepancy and if you have a targeted therapy initially, then even though like if you were to, you should use the HER2 therapy even in the metastatic setting, even if you have a low HER2 or loss, because there can be heterogeneity. And second thing is same thing applies to the hormone receptor, that if you have a loss of the hormone receptor, okay, you might intersperse with chemo, but then finally you should put them back on hormonal therapy. So do you have to say anything about this?
So, madam, if it is a talk about a synchronous metastasis where the patient has a breast primary and the liver which has come negative, then I would understand and treat the patient with a trastuzumab or a anti-HER2 directed therapy. But if this patient has recurred after 2 years and the HER2 is negative, I'm not comfortable in using a trastuzumab based treatment as my backbone. I'd rather prefer to use chemotherapy because we know that clonal change
you
can
would be
occur.
using chemotherapy
Definitely.
even with
Yes.
Yeah.
But what happens is this patient is going to require subsequent lines of therapy. So even again, if I don't answer the question today by doing a biopsy, tomorrow when the patient progresses, I will have to do a biopsy to again confirm.
Anybody in the audience has any views on this discrepancy in the receptor status in the primary tumor and then once the patient metastasizes? Dr. Mehboob.
No, I agree with Nilesh what he said, that if suppose HER2 comes negative this time, yes, chemotherapy backbone is going to be there all the time, but I will not be I will be hesitant in adding anti-HER2 therapy. I will go ahead with the chemotherapy and see the response.
Now, I'll just tell you that when you use neoadjuvant anti-HER2 therapy, and if you were to see the residual disease, then almost 20% would lose the HER2 positivity. But they say that you should still have the anti-HER2 therapy in the adjuvant setting.
So that there again, the explanation is the direct effect of chemotherapy. And I would agree that there I would definitely continue. And there the HER2 presence in the post-neoadjuvant therapy specimen, I would not give so much importance to.
Okay, so
we all know that it's a heterogeneous disease. The clone of HER2 positive because of adjuvant therapy might have got suppressed, and only the HER2 negative clone might have come up. That may be a possibility.
Okay, so now we've done with the issue of biopsy. I want to know, let's start with you, that in this patient, what would be your first choice of treatment? Patient has
Definitely.
received trastuzumab 2 years back. And then,
Since we have covered already 2 years, we'll be rechallenging with trastuzumab again, if affordable, a combination of pertuzumab with taxane.
yeah. And any of you have anything?
I think I agree. It's more than 1 year, we can do a Cleopatra on this.
Yeah. Now, if the patient is also hormone receptor positive, then what would you do? Where do you add the hormone therapy as
Once
well?
I finish the chemotherapy, then I would add hormones along with the immuno.
Now, suppose this patient was HER2 positive and hormone receptor positive to begin with, and then had a progression. So, would you change both? I mean, the patient has a progression now. Patient was on hormonal therapy after completing with the trastuzumab, after the chemo was completed, and now the patient has got metastatic disease and is triple positive again. So what would you change? Like, would you change both or you'd change one or what?
So if the patient has progressed on a drug like tamoxifen, once I complete the second line therapy, chemotherapy, I would probably shift to letrozole or anastazole, one of the AIs. But if the patient has progressed on an AI, I would probably consider a shift to fulvestrant or a similar drug.
Yeah. So I think there is no way. Yeah.
When they have failed in the adjuvant setting, and I would like to see the tempo of disease. If the disease is too much and florid metastatic disease, then probably I'll add chemo and then add.
No, he's saying
It's
the
okay.
hormonal-
Yeah, then that's I agree. I completely.
Yeah. Anybody else in the audience has any Okay, then so now this is, you have mentioned pertuzumab, trastuzumab and docetaxel if they can afford. And suppose they can't afford pertuzumab, what about trastuzumab, lapatinib and capecitabine? What is your views on that combination?
So for non-affording patient, you have to rely on whatever available, accessible to that poor patient. Then combination of capacitor and lapatinib is also okay for me, and it has worked actually as a maintenance treatment also.
Yeah. Now, suppose this patient doesn't have extracranial met and has only an intracranial met, single. Forget about the liver lesion. Then what will you do?
So now we have to understand that this disease is going to fail in the brain, and the drug has actually worked and controlled the systemic mets. Patient is 57, young fit patient, 2 years of disease-free interval. You should definitely give a choice of ablating that resistant clone and continue whatever treatment with the multidisciplinary treatment, getting the surgeon on the board, adjuvant radiation, and then treat as a oligometastatic disease.
So what I'm trying to say is, now this is 2 years down the line from trastuzumab. Patient has developed a single lesion in the brain. You are going to, of course, excise is if there is a single lesion and then give SBRT. What are you going to do about systemic? Are you going to start systemic therapy or you will wait?
So I would suppose this patient has not received trastuzumab, you say?
No, has received.
Has received trastuzumab.
Completed.
So now we have a tissue to analyze again ERPR HER2. If it is ERPR positive, it is HER2 positive. Now after the resection, this is a very tricky question. I do understand, there is no circulating tumor cells circulating, it may cause another metastasis. Then the SBRT or whole RT is a big question. We always debate. If WRT is given, then observation is also one of the choices, because continuing TDM1 or trastuzumab throughout the life as a maintenance or pseudo-origin 1 year, I will give option of surveillance, close surveillance.
What I'm saying is, that's the thing.
So if it is an isolated CNS metastasis coming in 2 years after the primary treatment is over, tumor is resected and surgery is done, I would consider this as oligometastasis and treat it in the adjuvant sense. Probably just give 1 year of trastuzumab rather than continue it till progression.
So whichever you choose, observation versus 1 year.
I think both would be fine.
Anybody in the audience, what will you do? Like 2 years of after 2 years of adjuvant trastuzumab, patient has a single met in the brain which is treated. Would you give systemic therapy or you will observe? Anybody, Dr. Vaid, what will you do?
I think systemic therapy would be warranted, because ultimately there is some disease in the circulation somewhere.
Dr. Chetan, what will
And
you?
it will be like an adjuvant. I would use an.
So the best adjuvant, if at all I have to give, I would give an oral tablet, because then putting that patient on the pertuzumab, trastuzumab, docetaxel for no residual disease, we really don't know, there is no data, absolute no data. Then I would put a patient on the maintenance oral capacitabine and lapatinib.
So
the convenience of tablet is left to the patient. If she is willing to take injectable therapy, systemic therapy, then the option I would offer her as systemic therapy as an injectable treatment. If the patient volunteers that I don't want injectable, then it's okay.
So
but somehow lapatinib.
So you will give some systemic therapy.
Yes, definitely.
I think in this probably a doubtful scenario, can you do a CTCs in here? Suppose somebody has a no CTC which may have a risk of coming back. That's where probably you can tailor the so-called pseudo-adjuvant treatment.
So the CTC validation for HER2 has not been very good, and that's why we'd probably not use it in conventional practice. And all these patients will be excluded from any standard trial. So I guess it is on a case-to-case basis.
Similar way, we don't have a pseudo-adjuvant data. So doing a CTC and giving a pseudo-adjuvant, I would put in the same level. So if somebody wants to go ahead, doing a CTC would also help us to take a decision.
Mehboob, what will you do?
So that was a resected CNS metastasis, single lesion, resected RT given. Would you consider anything in the systemic therapy?
HER2, yes.
HER2 positive disease, completed adjuvant trastuzumab 2 years back, has a single metastasis intracranial, no extracranial disease, and proved, like treated, and it's proved that it is HER2 positive. So will you give systemic therapy?
I had similar patient like this, and I have not given an adjuvant, I have not given any systemic therapy, only the local treatment.
So it's a 50-50, and I don't think you have data really, except that one, if you continue the trastuzumab, it has some benefit intracranial, but we don't know.
Ma'am, if the
So-
same patient has failed within 6 months, what's that
Then
gonna
you
do?
would, then you would.
I mean, in that adjuvant trastuzumab or TDM1? I would definitely. I would
We'll come to that.
So problem is that we
um,
don't do brain imaging at baseline. Who knows that brain mets is sitting over there from the beginning, and no, it has grown and
No,
caused
but
symptom.
2 years, I mean.
Could be. No, we don't know the disease biology. Sometimes that is how the circulating tumor cells
So
are
I
causing
think, yeah.
recurrences.
I'll skip this because it comes to the same de novo MBC. Now, if the what is the option if the trastuzumab is ended more than 12 months before? So, what is the cutoff for you to use a second line anti-HER2 therapy in the metastatic setting versus first line?
The Cleopatra says more than 12 months, ma'am. But even if it is more than 6 months, I would be comfortable using a trastuzumab and docetaxel.
Actually, in the ESMO guidelines
6 to
and all,
12
it's
months.
mentioned more than 1 year.
6 to 12
It
months
means
also.
6 to 12 months is a gray area,
it's a gray
but 12 months is acceptable. 6 to 12 months, you can use either. So that is the thing. And then this we have 6 to 12 months, you have already answered. So now second line HER2 positive. So this was a 45-year-old with a node positive disease, HR negative HER2 positive, 6 years ago T2N1 M0. She underwent a mastectomy and axillary node dissection and adjuvant treatment with 4 cycles of AC and 12 cycles of weekly Pacli. 4 years later, she developed HER2 positive HR negative liver metastasis, treated with weekly Pacli in combination with trastuzumab, and then continued on trastuzumab alone. And then a new lesion is found in her liver. Now, maybe at that time, the combination was not available, so she has used only trastuzumab. And now on progression, what will you use? I mean, one more is missing there. I would have to put it now. Yeah. So, like, what would you use now?
TDM1, I think this case for a TDM1 as of now. If the patient's affordability is there, then TDM1. If affordability is not, then lab cape will be the next one.
So the only other thing is that now we know after Destiny 03, it's the Durexistican which is used as second line over TDM1. So apart from the low HER2 positive patients, this is the indication now for second line rather than third line. So it has trumped TDM1. So it's the approved second line now.
If the patient has
So if
not,
that is missing, it should
that
have
patient
been
has
there.
not used pertuzumab upfront, can we?
Sorry?
If this patient has not used pertuzumab upfront,
Pertuzumab. Yeah.
so can we use it in the next line?
No, because it has to have trastuzumab as partner. No? So if you can't use trastuzumab, you can't use pertuzumab. Anybody has used any other combination with
So
pertuzumab?
before TDM1 was not available, there were people tried continuation of trastuzumab, changing to a different line
Yeah,
of
we did
that
that.
we have done, and it has actually worked.
Yeah.
So as he asked, no, then we can add pertuzumab also when you don't have an option of TDM1,
Yeah,
and
because-
you can probably manipulate them.
Yeah, because before all these second line therapies came, they did the study that you change the chemo and continue trastuzumab versus not, and those where it was continued did better. So that was before all the second line therapies came. So that is a thing. So now this is should I continue or we can finish? I think.
We could go 5 minutes, another 5 minutes.
Okay.
Smriti,
So-
can I ask one question? Like, you had a patient of 45-year-old. I also have one 45-year-old patient. I don't know what to do. That's why I'm asking. She had been received ACTH earlier, recurred after 3 years, and she was triple positive, ER positive and HER2 positive. So she was on hormone therapy. Now she recurred in liver and brain, brain treatment done, and she received TPH, okay, as Cleopatra. She has done very well, good response, completely gone. Incidentally, she was also found to have BRCA positive. Now she's triple positive plus BRCA positive. Now in maintenance, what to do?
Well,
When to add
see, the
the
Olympiad study was in HER2 negative patients. So you really don't know like what to use. It's a data-free zone. So in the Olympiad study, so what will you do? Like he said, she's BRCA positive as well.
I would probably leave it for a subsequent line of treatment rather than using it here simply because there's no data on it.
Yeah, I mean, I'm also doing same thing. I continued with pH plus the letrozole and continuing on that. Let's see what happens.
You see, just for the interest, you see a BRCA1 and BRCA2, sir? I think is it detected incidentally, or is it this HER2 positive disease was sporadic and this was just a regenerative which was just incidentally detected?
No, no, it was germline because as patient becomes metastatic, then move around. So somebody asked for the BRCA.
What I'm telling is the
So
breast cancer may be just a HER2 positive which was sporadic. She may be carrying the genetic abnormality, so which maybe we're unnecessarily targeting. That's the contention. May have to probably do it in the tissue, then we'll be able to identify whether it is related.
Since we have only since we have only 3 to 4 minutes, instead of going through this case, I just want to ask you if you have a de novo a triple negative MBC, and then the patient is germline positive. Now, what treatment would you offer that patient first? Immunotherapy, or you would use this olaparib, or what? Like, you go for immunotherapy or olaparib?
So if I also have data about the CPS 2 to C being more than 10%, then I would probably prefer to use an immunotherapy backbone because it actually also has a taxane and a platinum included in it. So I think that will be a surrogate. She'll be a surrogate responder for a platinum also, and probably use an PARP inhibitor in the second line or in subsequent settings.
Now
What
we
is
may
the
have
patient population of Olympiad? What was the patient population of Olympiad study? The
Triple
Olympiad.
negative and ERPR positive and HER2
Positive.
negative.
And no, how many prior lines of therapy?
I think 2 lines.
Yeah, so two lines of therapy. So that is why, it doesn't mean that you have to use it as first line. You can use it in later lines. Yeah. And suppose the patient had received 2 lines of therapy, is positive for BRCA, and also now would you use sacituzumab or you would use the olaparib?
So, madam, the challenge with any of these PARP inhibitors is the condition that they should not have received a platinum before. So, if they have received a platinum before, generally the responses to the PARP inhibitors are lesser. And in such a situation, invariably in the first or second line, the patient would have received a platinum. I would probably go for sacituzumab govitecan as the next line of treatment.
Yeah, but suppose the patient has not received a platinum, has received single agent anthracycline, then taxane.
So that's again a gray zone where we don't have any trial data for that.
Anybody, Dr. Vaid or Mehboob Basari, this was the last question.
I think now it becomes a patient choice. Here, we have to sit with the patient and take a call
Yeah,
rather,
so
because
these
you have
are
all these options
some of the
available.
tricky
Yeah.
areas, you
So
don't know.
There was a consensus meeting, or a big consensus meeting in ASCO, and the consensus, majority of the participant felt that if you have to use IO and olaparib, you should start with IO and then switch over to olaparib.
Yeah, so I think with that, I'd like to thank the panelists and also the organizers. Thank you.
Thank you, Dr. Smruti, for that wonderful moderation. Friends, no doubt we had a wonderful pre-lunch session dwelling on the various aspects of early breast cancer and also in the metastatic setting. I think after this hard work, it's a well-deserved lunch. We can disperse for lunch, and since the next section starts sharp at 2 o'clock, and we have an international speaker on that program, so I request everyone to be available by 2 o'clock, sharp 2 o'clock. Thank you so much.
From ISO, there are some participants who have to go early. So Indian Society of Oncology has a small memento for this occasion, which I would request you to collect from the desk before you leave. to pay attention, and I would request Dr. Shyam Agrawal to take over.
ચાલુ નહીં કર્યું ને હજી.
Hello, Professor.
Hello. I'm fine. Can
Are
we
you
just?
ready, sir? Are you ready with your presentation?
Can I ask just one question? We have time for the presentation and then time for questions. Is that right?
Yes.
Go ahead, and my audience is already ready, eagerly waiting for your presentation. Thank you.
Okay. Thank you very much. It's a pleasure to be speaking to you, although it would be much nicer to actually be there with you in India. So what I've been asked to speak about is a particular issue, the use of one chemotherapy drug, eribulin, in the treatment of people with metastatic breast cancer. I'm an oncologist working in Leeds in the north of the UK, which you see a panorama at the bottom of the slide. And I work at the university, also as a consultant at the hospital, and running our research facilities across Leeds. So I'm trying to get the slide to move down, and it isn't, I'm afraid.
Sir, do you want us to move from here? Your slides?
Yes. If you're yes. Sorry, I thought I was controlling the slide. So next slide, please.
Just a second. You need to stop your share screen.
Okay.
Okay, sir. Can you move the? You just need to tell the next slide, please. All right. Check.
So I'll ask you to move the slides. Correct?
Yes.
Yes. So next slide, please. So apologies for that. So these are my disclosures, and just as a point of interest, one of the additional roles I have of late is that we have established a charity in the United Kingdom, specifically looking to provide support for people with triple negative breast cancer. Next slide, please. So these are the areas that I'd like to cover today. We'll go through each of them in turn and hopefully come to some conclusions at the end there. So next slide, please. Next slide. So by way of introduction, we all appreciate that when we make decisions with patients regarding treatment for metastatic breast cancer, there's a whole range of different things that we take into account in terms of the patient characteristics, the characteristics of the disease, patients' prior treatment, and also the important distinction between people who we see in routine practice compared to those in the clinic. But I think a relevant question to ask is, what are the different priorities for our patients, their carers, and their doctors? Next slide. And one of the things that I think is we can look at in terms of the clinic, what amounts to clinical benefit for our patients, is I think they want to maintain or improve their quality of life. They want to see their tumor symptoms improved, and people also do want to have prolonged overall survival. So I think improved overall survival is one of the 3 key treatment goals for patients, also for regulators, but I think it should be for us as physicians to look to see how we can prolong survival for our patients, so that we, at the same time as maintaining quality of life and relieving their symptoms. Next slide. Over the years, there had been some loss of focus on overall survival in the context of clinical trials because it had been viewed as too difficult to demonstrate improved overall survival in people with metastatic breast cancer. And we placed great emphasis on looking at progression-free survival. But surveys such as the one that you see here, where people with cancer were asked to rank the importance of different outcomes, to them, you can see that on the left there, the ability to improve survival was scored highest, 4.2 out of 5. People were interested in slowing the cancer growth, maintaining their high quality of life, but the most important single element was to improve their survival. Next slide. As I said, progression-free survival had become what was accepted within clinical trials as the primary endpoint for many years. But I think it is fair to say that there are limitations to progression-free survival. The evidence that progression-free survival correlates with overall survival is not strong. And in some ways, our use of progression-free survival as a surrogate for overall survival was at least in part because we recognized or believed that to demonstrate overall survival was likely to be too challenging, might require trials that were too large. But I think overall survival, as we've seen in the earlier slides, is still a key endpoint for our patients. Next slide. Having said that overall survival is an important endpoint for our patients, it's striking how relatively few trials in people with metastatic breast cancer have overall survival as a primary endpoint. These data are a little historical now, but over a 20-year period between 1994 and 2014, you can see that only between around 10% of trials, phase 3 trials in metastatic breast cancer, had overall survival as their primary endpoint. And that was irrespective of whether these were trials on chemotherapy, targeted therapy, or endocrine therapy. Next slide. Nevertheless, I think there is a strong argument that overall survival should be a clinical trial endpoint. It remains the gold standard from the point of view of the regulatory authorities. It's important for patients, but in many cases, it hasn't been adopted as a primary endpoint, really for historical reasons. Next slide. When the development of eribulin was undertaken, and we're looking back some 20 years ago, we were very conscious that eribulin, if it were taken into clinical practice, would be one of a number of different chemotherapies that were already available to treat people with metastatic breast cancer. So we were very clear that if we were going to take it through into the clinic, it had to be because this new drug did offer something genuinely different. We didn't want this to be simply a Me Too treatment. We wanted eribulin to bring something new that hadn't previously been available. And for that reason, overall survival was indeed selected as an endpoint for the key phase 3 trials for people with metastatic breast cancer. We felt that this was a high hurdle, that it would be a great challenge, but if we were able to demonstrate for the first time improvement in overall survival in people with heavily treated metastatic breast cancer, we felt that would be an important clinical advance. And here you see in the bottom right-hand side of the slide, the data from the key study, which you'll be familiar with and which we'll refer to a number of times today, the so-called study 305, which looked at people randomized to receive either eribulin or one of the alternative chemotherapies, treatment of physician's choice. And you see there with a 2-to-1 randomization, there was an improvement in overall survival as the primary endpoint of 2.5 months. This was statistically as well as clinically significant. The other key study that looked at eribulin in people with metastatic breast cancer, study 301, also had overall survival as a co-primary endpoint, as we'll discuss later. But I think this study here, EMBRACE or study 305, was important because it showed that improvement in overall survival was indeed attainable. And that was something which up until 10 years ago, when this study reported, hadn't been accepted as being possible and hadn't been accepted often enough, I think, as a primary endpoint for these phase 3 trials. Next slide. Here you see another trial which you may be less familiar with. So study 301, which was the comparison of eribulin with capecitabine, and study 305, the comparison of eribulin with treatment of physician's choice, were published several years ago. The third large randomized trial that looked at eribulin was this trial comparing eribulin with vinorelbine, which was conducted in a Chinese population of patients. And this had overall survival and progression-free survival as co-primary endpoints. Next slide, please. Here you see the results from that study, looking at the progression-free survival according to independent review, which you see here. And you can see that the curve on the blue curve for patients treated with eribulin is to the right of the curve for the people treated with vinorelbine. Although there was no difference in the progression-free survival at the median time points where the curves come together, you can see that at other parts of the curve there is separation, and the study showed improvement in terms of a hazard ratio of 0.8, a p-value of 0.036 with respect to or with favoring eribulin with regard to progression-free survival. In terms of overall survival, again, the data favored eribulin numerically, 13.4 compared to 12.5 months, but that wasn't statistically significant. So the two key studies, 301 and 305, which you'll be familiar with, but also this more recently published study, study 304, have all shown eribulin to be superior to the control arm of vinorelbine here, capecitabine in study 301, and treatment of physician's choice in study 305. Next slide. So I think what I would say in terms of the context of the data and the trials that we'll look at today is that overall survival is an important outcome for all of us, including our patients. And eribulin remains the only cytotoxic that has shown improved overall survival following an anthracycline and a taxane. It was the only such agent 10 years ago, and that remains the case. Next slide, please. I'd now like to look at the use of eribulin across the different subgroups of patients, starting with the single largest group of patients currently, those with hormone receptor positive HER2 negative disease. Next slide. This is something that we looked at in a review that was published just a year or so ago, which looked at the continuing place of chemotherapy in the context of all the advances and changes that are taking place with regard to endocrine treatments for this group of patients. But despite all of those new endocrine treatments, chemotherapy does still have an important place in treating people with hormone receptor positive HER2 negative disease. Next slide. This is an overview of the ABC5 guidelines for treating this group of patients. And as everyone will be familiar, for the majority of these patients, endocrine therapy is the preferred option in the first line. And for patients who benefit from endocrine therapy in the first line, they may be candidates for second or third line endocrine therapy. Those who maybe have impending visceral crisis, we may opt for chemotherapy in the first line. But even in the people who receive endocrine therapy first or second line, in due course, they will exhaust their endocrine treatment options and will need to look at what chemotherapy is best for them. Next slide. So here we have the data from those two pivotal trials that you'll be familiar with, eribulin compared to capecitabine and eribulin compared to treatment of physician's choice. These are the results of the pooled analysis, looking at both of the studies together. And highlighted at the top, you see the series of forest plots, and at the very top is the overall population, where you can see that there is a benefit for eribulin compared to the control arms, a statistically significant benefit there. Highlighted just below that is the group of patients with HER2 negative hormone receptor positive disease. Again, the point estimate is well to the left of the vertical, as it is across the other subgroups. So certainly in this major group of patients, capecitabine, the other treatments of physician's choice, were not performing as well as eribulin. Next slide. If we specifically look at study 301, which was the head-to-head comparison of eribulin with capecitabine, many of you will be familiar that although there was a numerical improvement in survival with eribulin compared to capecitabine, and I apologize for the spelling mistake on the slide there, that didn't reach statistical significance. Nevertheless, the hazard ratio certainly did favor eribulin. But one of the features of the area when we conducted this trial is that people with HER2 positive disease were also eligible. And so if we look at the whole group of patients on the left of the panel, that includes a proportion of patients with HER2 positive disease. On the right-hand side of the panel is a pre-specified analysis in the people with hormone receptor positive HER2 negative disease. And in that subgroup of patients, the difference in survival was 2.5 months. The hazard ratio was 0.84, the nominal p-value 0.0299. So were we to have conducted this trial in the current treatment landscape, where we would have excluded people with HER2 positive disease, then I think we would have seen a positive result. So I think, notwithstanding the issues around statistics and precise definitions, if we look at the population of patients that we're focusing on at the moment, those with hormone receptor positive HER2 negative disease, eribulin is clearly superior to the treatment of physician's choice cytotoxics, after an anthracycline and a taxane. Next slide. Quality of life, as we said at the outset, is important, and quality of life was looked at in that study 301, and I think it's very encouraging that eribulin did not show any negative impact on quality of life compared to capecitabine, because we would consider, most of us, that capecitabine was a well-tolerated treatment. So the benefits in terms of overall survival from eribulin in this group of people was not at the expense of quality of life. There were some differences in quality of life that reflected the different patterns of toxicity, but overall, there was no negative impact on quality of life from the more effective treatment with eribulin. Next slide. So in this particular group of patients, the hormone receptor positive HER2 negative patients, the clinical trial data clearly support the use of eribulin, again, the only cytotoxic with overall survival benefit. In terms of the other cytotoxics that are used, the evidence to support capecitabine is stronger than that for single agent vinorelbine or gemcitabine, but when compared to capecitabine, as we've just seen, eribulin was clearly more effective, and that was demonstrated in terms of improved overall survival. Next slide. Moving on now to people with triple negative breast cancer. Next slide. Here you see the ESMO algorithm for treating advanced triple-negative breast cancer. Again, the landscape here has changed since we carried out those pivotal trials with eribulin, but you see laid out there the algorithm, including the potential use of PARP inhibitors in people with BRCA mutations, of immunotherapy combinations in people with PD-L1 positive tumors, and the more recent addition of sacituzumab govitecan, the antibody drug conjugate, as clearly a highly effective agent. Again, though, patients will exhaust these more targeted treatments and the antibody drug conjugates, and the question then becomes, which of the standard chemotherapy agents should we be looking towards? Next slide. And the choices that I think most people would look at, and the ones that were highlighted in the ESMO algorithm here, are eribulin, capecitabine, and vinorelbine. So the question we'll look at now is whether indeed these are equal options, equal in terms of their efficacy and benefits, or whether indeed there is one that can be preferred. Next slide. In terms of chemotherapy more widely for triple-negative breast cancer, the TNT trial is one that you'll be familiar with in people with metastatic triple-negative breast cancer, which compared docetaxel with carboplatin. The panel on the right shows the overall response rate in the intention to treat population on the left there, which shows that the response rates were very similar with carboplatin and docetaxel. But on the right-hand panel of the slide, in people with BRCA-mutated cancers, the carboplatin was clearly superior. Nevertheless, I think these are important data because they do demonstrate the significant role, the important role of carboplatin in people with triple-negative breast cancer, irrespective of their BRCA status. So carboplatin clearly is a relevant agent. Next slide. We also have other data. This is the Tenacity trial, which was a randomized phase 2 trial, again in the first-line setting in people with metastatic triple-negative breast cancer. And there were 3 different treatments looked at, as you see there, nab-paclitaxel and carboplatin, nab-paclitaxel and gemcitabine, and gemcitabine carbo, the combination on the right. This wasn't formally powered as a phase 3 trial, but if we look at progression-free survival and look at overall survival, as highlighted in, on the left-hand panel of the part of the slide, you can see that both of these were superior in the people treated with nab-paclitaxel and carboplatin compared to the other 2 regimens. So again, I think that emphasizes once more the role of carboplatin. Next slide. But moving on to eribulin, again, we're able to look at the pooled analysis of study 301 and 305, eribulin compared to capecitabine, or eribulin compared to treatment of physician's choice. Highlighted at the top of the slide, again, the overall population showing the significant benefit in overall survival for eribulin compared to the control arms. But in the middle there, you see highlighted the patient population with triple-negative breast cancer. And again, as with the other subgroups, the point estimate is to the left of the vertical line, showing benefit from eribulin that is statistically significant, but the benefit does seem particularly marked here. Next slide. This is another subgroup analysis, this time specifically looking at the people, the study 301. So this is people with metastatic triple-negative breast cancer randomized to receive either eribulin or capecitabine. And you can see that in the panel on the right there, you can see that the eribulin curve is significantly and substantially to the right of the capecitabine curve. There is some improvement in progression-free survival from 2.9 compared to 2.3 months, but a very marked improvement in overall survival with 14.4 months overall survival with eribulin compared to 9.4 months with capecitabine, the hazard ratio of 0.7 and the nominal p-value 0.006. So clear evidence to support in the triple-negative patients eribulin over capecitabine. Next slide. So here we have a slide really looking at the conventional chemotherapy options that we use in our own practice in people with triple-negative breast cancer. Our standard first-line treatment in these people would be a taxane in the form of weekly paclitaxel or platinum, and I would usually use carboplatin as a single agent rather than in combination. In the second-line chemotherapy setting, we don't have access to eribulin. It's not reimbursed, so we would often use the regimen we hadn't used first line, but were it reimbursed, I think in the UK we would be keen to use eribulin second line rather than third line, which is where we would use it conventionally. And I think it is important, and we'll come back later to this issue of using the more effective drugs earlier as an earlier line of treatment. Next slide. So For people with metastatic triple negative breast cancer, certainly my preferred second or third line chemotherapy agent is eribulin. We see that 5 months overall survival advantage compared to capecitabine, and I think that those are powerful data that suggests that eribulin should be used in advance of capecitabine or indeed vinorelbine and gemcitabine in triple negative disease. Next slide. Well, what about some other of the subpopulations of people that we treat? What I'd like now to look at is people with HER2-low breast cancer, HER2-positive breast cancer, and specific analyses we've done looking at people with visceral disease. Next slide. When we were doing the pivotal trials with eribulin, the concept of HER2-low didn't exist. We simply would classify people in the conventional way as having HER2-positive disease if they had 3+ scoring on immunohistochemistry or FISH, and everything else was defined as HER2-negative. Of late, as you'll be very well aware, it's become apparent that this is an oversimplification, and what we previously considered HER2 negative can now be divided into other subgroups, and more specifically into the HER2 low group, which would be the people with a 1+ on the immunohistochemistry or 2+ on the immunohistochemistry, but are FISH negative. And then there are other people who are genuinely HER2 negative or HER2-0, I should say, and those would be people with no staining at all. So we're now moving into a different era where we're looking at 3 categories of people with regard to HER2 positivity: those who are clearly positive, those who are clearly negative, and that middle group of HER2 low disease. Next slide. We've been back and looked at study 301 and 305 in that pool in the pooled analysis, and have presented data just this year at ESMO, looking at the subgroups according to HER2 low on the left and the HER2 0 on the right. These studies weren't powered for any statistical formal comparison, but you can see that both in the HER2 low and the genuinely HER2 0 populations, the eribulin is performing better than the control arm. The separation looks potentially wider in the HER2 0 group with a hazard ratio of 0.78 compared to the HER2 low group. But I think this data emphasizes again that in that HER2 low group of people that we will see as we start to retest or test anew our patients with metastatic disease, that eribulin remains a preferred agent compared to capecitabine and the treatment of physician's choice in that newly emerging population of HER2 low breast cancer. Next slide. Now moving on to HER2 positive breast cancer. Again, this is the pooled analysis, and you see here that in the limited number of people who were treated in the Embrace 305 and Study 301, that limited number of people who were treated, there's just over 100 people that were treated who had HER2 positive disease. The point estimate for people with HER2 positive disease again favored the use of eribulin as a single agent compared to other single agent chemotherapies. Next slide. Because HER2 positive disease is an area where the emphasis has been on the HER2 targeted therapies rather than on chemotherapy in recent years, there hasn't been a lot of development of eribulin in people with HER2 positive cancer. But here you see a study that was led by Linda Vardat some 10 years ago that was not randomized, but a phase 2 study of just over 50 people with metastatic breast cancer. They were HER2 positive, and this was looking at the combination of eribulin and trastuzumab at the conventional doses as first-line treatment. And you can see that the overall response rate in people, in the 40 patients who were evaluable, was just over 50%. The clinical benefit rate, and that required stable disease to be maintained for 6 months, was even higher at just over 60%. So the combination of eribulin and trastuzumab, although not widely used, is one which is highly effective in the first-line setting. Next slide. That is emphasized again. This is the same trial, the same data, but looking at the waterfall plot at the top there, you can see that it really is very impressive that there's only a couple of patients who progressed immediately through their treatment with eribulin and trastuzumab. The majority of patients benefiting to a greater or lesser extent, and just over half of them having formally confirmed partial response. The progression-free survival data are shown in the bottom part of the panel, and the progression-free survival was nearly 12 months, which again I think is impressive and suggests that eribulin would actually be a very reasonable partner for trastuzumab in people with HER2-positive disease. Next slide. The third category of people that I'd like to look at are those with visceral disease or more difficult to treat, more aggressive disease. And again, we can look at that pooled analysis of study 301 and 305. And in the panel at the bottom of the slide, there you see a couple of subgroups which we've pulled out. There's the group with less than or equal to 2 organs involved, and those with more than 2 organs involved. And you can see that the improvement in overall survival is more marked for the people who had more advanced disease, just over 13 months compared to 10.5 months. Similarly, if we look at people with visceral disease and non-visceral disease, the outcomes are better for people with non-visceral disease, as we might expect, but there is benefit in terms of improved overall survival with eribulin for both visceral and non-visceral disease. Next slide. We revisited this again a couple of years ago with another look at these data, and it was an exploratory subgroup analysis of specific metastatic sites. And you can see there that we've looked at a number of different sites of metastasis on the right-hand part of the slide. Next slide, please. And specifically, I draw your attention to the patients with liver metastases, which I think we all would recognize as being a particularly difficult patient group to treat. And you can see here that we have benefit in terms of improved outcomes for eribulin compared to the control treatment arms. Next slide. And those data are shown here for the patients with liver metastases. And in this subgroup analysis, we can see that there's significance or clinically significant improvements in overall survival, quite clear separation of the curves favoring the use of eribulin. Next slide. So the benefits of eribulin extend to people with HER2-low disease, those with HER2-positive disease. I apologize for the missing E there. That should be HER2-positive metastatic disease, and also those with more aggressive disease, including people with liver metastases. Next slide. What other evidence is there? Because clearly these trials date back several years, but other data have become available, both in terms of real-world data analysis, but also some systematic review and meta-analysis. Next slide. You'll be familiar with real-world studies. The advantage of real-world studies is that they more closely represent the people who we treat in our regular practice than patients in clinical trials, who are invariably younger, fitter, having fewer concomitant medications compared to the real-world patients. The downside, the disadvantage of real-world studies is that we don't have a formal comparison arm, and the populations may be biased in some way, and there aren't the same clear rules or conditions for how these data should be analysed as yet. But I think the data can be interesting to look at this more relevant group of patients in terms of our everyday practice. Next slide. There have been a number of studies done with eribulin. This is a real-world study reported by Sarah Mugalian from the United States, looking at people treated, and there were just over 500 people treated with metastatic breast cancer, a chart review looking at outcomes in terms of response rate, progression-free survival, and overall survival over a prolonged period of time. Next slide. Next slide, thank you. Oh, I'm sorry, if you just go back a slide, we got out of sync there. That's the right slide. So this is the real world evidence for that population of 500 patients. The overall response rate was 54%. Now that's much higher than we've seen reported in the clinical trials, and probably reflects the fact that this was a clinical assessment rather than a formal assessment according to RESIST. But the progression-free survival of 6 months and overall survival of 10.6 months, I think, are encouraging in the real-world population. And specifically, they looked at the people with triple-negative breast cancer, and although triple-negative breast cancer has an inherently worse prognosis, you can see that outcomes in the triple-negative patients were similar to those in the overall population, again suggesting that in the real-world situation with people with triple-negative breast cancer will be benefiting from eribulin. Next slide. They subsequently published data also about a more focused group of people, and these are patients with with hormone receptor positive disease who'd been treated with a CDK4/6 inhibitor. And clearly, CDK4/6 inhibitors didn't exist when we did the pivotal trials with eribulin. So these real-world data looking at the use of eribulin after endocrine therapy along with a CDK4/6 inhibitor are relevant to our current clinical practice. Next slide. And these are the data there. If we look at the top left, this is progression-free survival. There were 3 different cohorts of all of whom received eribulin in a slightly different setting. The red curve, which is the curve on the top, is the patients who were treated in the second line and beyond setting. And although we don't have comparator arms, clearly those patients are doing well. And in the bottom right, we have the overall response data for the different cohorts. But overall, the response rate was about 30% in this overall cohort of patients. So this again would support the use of eribulin following endocrine therapy that included a CDK4/6 inhibitor. Next slide. A larger real-world evidence database comes from France, where a large number of major centers that you see highlighted on the map on the right-hand part of the slide has come together, and they've collected data on over 15,000 patients with metastatic breast cancer, and have looked specifically at the 1,481 patients who received eribulin as second, third, or fourth line chemotherapy. Next slide, please. So this is the patient group that they started with, the 16,000 patients, the 14,500 patients with known ER/PR and HER2, and out of those 7,500 patients received 2, 3, or 4 lines of chemotherapy. And they were able to look at the efficacy or the outcomes in people treated with eribulin compared to those receiving other chemotherapy in the second, the third, and the fourth line setting. Not a randomized comparison, but a real-world comparison. Next slide, please. These are the key data in terms of overall survival in the second, third, and fourth line setting. In each case, the patients treated with eribulin in the blue curve are doing better than the patients who received the other lines of treatment. And the magnitude of that benefit differs partly for some technical reasons and partly because of the use of trastuzumab in some of these patients. But I think a consistent pattern that in the second, the third, and the fourth line settings, eribulin is outperforming the other chemotherapies that patients were being treated with. Next slide. And finally, there is a systematic review that was published there. The reference is in the bottom left. It was a systematic review and a meta-analysis that was done of the various studies looking at eribulin that you see listed on the slide here. And the forest plots shown for the individual trials, but also for the pooled data looking at overall survival. And at the bottom, you can see that there is a consistent pattern favoring eribulin compared to the control treatments regarding overall survival. Next slide. In terms of toxicity, they looked at neutropenia, and in this case, there was neutropenia was actually seen more frequently with eribulin. So eribulin performed less well in terms of neutropenia, but we all know that the neutropenia that is seen is invariably asymptomatic neutropenia, not something that the patient is aware of, and something that very rarely leads to neutropenic sepsis. So not, I think, a concern. Next slide, please. But what is interesting when looking at all grades of neuropathy is that although we know that eribulin can cause neuropathy, there was no data to suggest that eribulin was more likely to cause neuropathy than the other treatments that were used in these clinical trials. So I think that is reassuring that the benefit in overall survival across the clinical trials is seen, and that it isn't at the expense of increased neurotoxicity. There may be more myelosuppression, but that will be asymptomatic in the vast majority of cases. Next slide. So for me, these real-world data and the meta-analysis again support the use of eribulin. Next slide. So finally, the question of sequencing of chemotherapy. Next slide. We have no shortage of agents, including cytotoxic agents, available to treat our patients with. But I think an important question is when we should be using them. And if we look at the eribulin data, I think we see a consistent pattern that eribulin is more effective when it is used in patients who are less heavily rather than more heavily pre-treated. Now, the trial data, as you know, are in people who received an anthracycline and a taxane. But if we look in EMBRACE study 305 and look specifically at the people who had received 3 or fewer lines of prior chemotherapy, which you see on the panel here, you can see that the separation of the curves favoring eribulin in terms of overall survival is clearly, the curves are clearly separate. So the benefits in overall survival, the median benefits in the people who are less heavily pretreated was 2.6 months. The people who are more heavily pretreated, who'd received 4 or more lines of chemotherapy, was just about 1.5 months. So if we're going to use eribulin, I think this is compelling evidence that we should use it sooner rather than later. Next slide. We can look similarly in study 301, the comparison of eribulin with capecitabine, and these are data, from Pivo et al. And again, you see that there is clear separation when looking at the patients within study 301 who were rather less heavily pretreated. They'd received the anthracycline and the taxane, but they were receiving eribulin in the second-line metastatic setting. And again, there's clear separation of the curves, 2.5-2.6 month improvement in overall survival, favoring eribulin over capecitabine with the hazard ratio that you see here. Next slide, please. Finally, on this note, we've mentioned briefly the comparison of eribulin with vinorelbine, the Chinese study, which showed a benefit of eribulin in the overall population. Highlighted on this slide are the forest plot data at the top for the number of prior chemotherapy regimens, and in the bottom, in the middle of the slide, the prior number of chemo regimens for locally advanced or metastatic disease. And the message is the same in both cases. The less heavily pretreated patients are the ones who are getting the improvement in progression-free survival. Next slide. And the reason why I think this matters is shown here in an analysis that we did some years ago, looking at a population of hormone receptor positive, HER2 negative patients who we treated in Leeds. And we looked at their successive lines of chemotherapy and endocrine therapy. And what we found consistently was that there was a drop-off and a fall in the proportion of patients who moved from one line of treatment to the next. So although many patients did go on to receive multiple lines of treatment, at each stage, at each point where the disease progressed, a proportion of patients will die, or a proportion of patients will decline or not be fit enough to continue treatment. So if we don't use our more effective agents early in the natural history of the disease, there's a risk that a substantial proportion of patients won't have the opportunity to benefit from them. And as we've seen earlier, eribulin is clearly more effective in the patients who are rather less heavily pre-treated. So we should be using it, I would argue, at as early stage of the disease as is possible. Next slide. And that is there, I think, summarized that the trial data and the real world data we saw earlier support the use of eribulin sooner rather than later in the natural history of the disease. So now if we move on to the next slide, and to the slide after that, here I would like to summarize what I hope I've taken you through with regard to the role of eribulin in treating metastatic breast cancer. So to reiterate, overall survival is important for patients, for us as clinicians, and also for the regulators, and eribulin remains the only cytotoxic to show improved overall survival following an anthracycline and a taxane. In patients with hormone receptor positive HER2 negative disease, the clinical trial data do support the use of eribulin, and that eribulin is more effective than capecitabine. In patients with triple negative disease, eribulin is certainly my preferred second or third line chemotherapy, with that 5-month overall survival benefit we saw compared to capecitabine. The benefits of eribulin extend to people with HER2 low disease, with HER2 positive metastatic disease, and those with more aggressive disease, including those with liver metastases. The real-world data and meta-analysis also support the use of eribulin, and the data that we have indicate that eribulin is more effective used earlier rather than later in the natural history of the disease. Next slide, please. So with that, I'll conclude and happily take any questions you may have.
Thank you very much. So, Dr. Sham, are you there?
Yeah, good afternoon. I'm here.
Yeah, please take over. Please take over.
All right. So thank you very much. That was a very, very crisp and elaborate talk on the role of eribulin in patients with metastatic breast cancer. I think we have 15 to 20 minutes, which is going to be focusing on a panel discussion on eribulin and the role in metastatic breast cancer. And for this, I have the privilege of inviting the panelists. I think Dr. Ajay Gogia is there. I think he's there from the All India Institute. Dr. Chanchal Goswami.
Yes, Sham, I am here.
Yeah, welcome, Chanchal.
Thank you,
Dr.
thank you, Sham.
Vishwanath.
Yes, sir, I'm there.
Wow, great. Dr. Manish Singhal and Dr. Ranga Rao. So I think Dr. Chanchal and Dr. Vishwanath are there. So I think we should be able to thrash out a few questions which are relevant to practice for the use of eribulin. I think the organizers do have the slides. Can you show the slides, please? Okay.
Yes, sir. We are. Yeah.
Right. So I can see the slide, and I think all the panelists who have joined can see these slides. So can we have the next slide, please? Okay. I think as we are aware, that eribulin has multiple, modes of action. So unlike taxanes and Vinca alkaloids, which are reversible microtubule inhibitors, eribulin is an irreversible microtubule inhibitor. So I think Dr. Chris Twelves has shown the utility of this drug in subsequent lines of chemo after the taxanes and anthracyclines have failed. So Chanchal, the question is quite loud and clear. Where do you place this drug when it comes to patient management for metastatic breast cancer, eribulin?
Well, Shyam, thank you very much for asking me the question. You see, there are very clear-cut indications as far as the role of eribulin in metastatic breast cancer is concerned. I will start with triple negative in the sense because the drug has been most profusely used in triple negative settings. And this has been primarily been used in third line as Chris has already elaborated. But I would prefer to use it in second line. And if even in metastatic breast cancer, if they have been exposed to anthracycline and taxanes in the adjuvant setting, I won't mind using it in the first line because the earlier we use eribulin, the better results we get. And so at this point of time, definitely my choice of eribulin would be in preferred line, in second line and third line, but I would not hesitate to use it in first line, provided the patient has already received anthracyclines and taxanes. And as far as hormone receptor positive disease is concerned, though we really treat them most of the time with multiple lines of hormone therapies and targeted therapies, but when the question of chemotherapy comes, I think eribulin is a good choice in using even in hormone receptor positive disease.
Okay, so it seems, you have selected the drug in patients who have been previously exposed to taxane and anthracycline. Dr. Vishwanath, what is your take? Let's put it in terms of a case scenario. A patient, who has been exposed to adjuvant paclitaxel or docetaxel and an anthracycline, and 1 year has elapsed, in a patient before she develops a metastatic disease. So would you consider using eribulin, or what is your thought process, Dr. Vishwanath?
So generally, sir, in my practice, I tend to go for gemcitabine carboplatin initially, then go for eribulin. Unlike the previous panelist, I do agree that using it early is always good because the performance status of the patient would be better. But in my practice, I generally use it after gem carbo, and even if the patient has received anthracycline and of course they should have received taxanes and anthracycline before.
Okay, and
obviously in the triple negative with the in the era of BRCA mutation positivity, even that has to be taken into consideration because the patient is BRCA mutated. Then in triple negative post chemo, we could probably use olaparib. So that also changes the scenario.
Great. So I think that has become an additional drug for patients who have a germline mutation in BRCA1, BRCA2. Can I have the next
Dr.
slide?
Shyam, sorry to interrupt you. Dr. Prashant Narayan has also asked before the panelist. Yeah, just to inform you. Yeah.
Okay. Yeah, I could see him, but then it was not in the list, so that's why I was not. So
yes,
that's great.
Yeah, thank you.
Prasad, Dr. Prasad, great to have you on the panel. Welcome, please. What about the place of this molecule in patients who are hormone receptor positive? So after they've failed the endocrine therapy, would you use it in the first line or second line? Where do you place eribulin today?
So, in practice, I would say, I will have to admit that I was not aware that this is the only drug, as we saw in the talk, which has shown survival benefit in hormone-positive metastatic breast cancer. Yeah. But I don't think in our practice we consider it in that way. Maybe it comes second or third as a chemotherapy option in these patients in my practice. That is what I would say.
So your first line would be something like, a weekly nab-paclitaxel?
Yes, sir. Yes, sir.
And for ER positive, subsequent to nab-paclitaxel, you would like to use eribulin?
Yes, sir.
Or you still have the use of anthracycline?
No, post paclitaxel definitely can be considered.
So is Professor Chris Twells with us still?
Yes, yes.
So I think you're listening to the discussion and the points of view of different doctors for ER negative and ER positive. So do you support the use of eribulin in an ER positive who has failed hormonal therapy, and taxane would be the first line in such patients?
We are limited by reimbursement issues in the National Health Service, but certainly were we able to, then I would certainly concur with what has been said. I think it's interesting in each of these disease settings that there are new targeted agents coming on stream. So obviously in hormone receptor positive patients, we're now routinely using an aromatase usually, and a CDK4/6 inhibitor. And I think all of us are aware of just how effective that combination is. But when people progress on that after that treatment, the subsequent lines of conventional hormonal agents seem to be relatively less effective. There may be a role for the PIK3CA inhibitors in due course, but it looks as though we see lesser benefit, or it's my impression that we see lesser benefit for second-line endocrine therapy or third-line endocrine therapy after people have had the CDK4/6 inhibitor. So I don't think that makes chemotherapy no longer relevant. I think it emphasizes that when these people come to receive chemotherapy, they should receive the most effective treatments. And that would usually be for us with weekly paclitaxel. But after the weekly paclitaxel, if we're able to, we would be keen to use eribulin sooner rather than later. One of the features of eribulin for me is that with the appropriate dose reductions, it is certainly a chemotherapy that you can administer a little bit like capecitabine on an open-ended basis. People tolerate it with appropriate dose reductions and can continue on it for many, many months. So I think it is an attractive agent for these patients.
So Professor Twells, if there is a patient who has, some mild neuropathy from, say, pre-existing diabetes mellitus, so would you, so what would be your sequence in such a patient, who has MBC and is requiring chemotherapy?
Well, I think for me, the neuropathy from eribulin is really pretty much manageable. It's not as problematic as it is with taxane treatment. And when we looked at people who did get a significant neuropathy in the study 301 and 305. This wasn't predominantly people who had pre-existing neuropathy. So I think it was quite clear that you need to be cautious. You need to obviously ask people about any symptoms of neuropathy, but the presence of pre-existing neuropathy isn't something, be it from the taxane or be it from diabetes, isn't something that would stop me using eribulin. I suppose what my sense of where eribulin belongs is at the top of after the taxane and the anthracycline, we think of capecitabine as maybe the third chemotherapy drug. I think when you look at the evidence in the round, in the hormone receptor positive, HER2 negative, and in the triple negative patients, I think the evidence is pretty convincing that eribulin should be considered ahead of capecitabine, and I think my practice has changed. Whereas many years ago, I used to think of eribulin and capecitabine as equal opportunities. I think I would suggest that we offer eribulin as the more effective agent. There may be some patients who would want oral treatment rather than intravenous treatment, and for them, capecitabine may be the preferred option. But I think if we delay the use of eribulin until after capecitabine, after vinorelbine, then we're going to see that the proportion of our patients who stand to benefit from eribulin will be less, and those who do reach eribulin in the later line setting are not going to derive the benefit from it they would have done if it had been used earlier.
Right, great. I think so, Dr. Chanchal. So do you agree, in a patient who has, mild neuropathy from, as I said, pre-existing diabetes, and the patient is, say, even ER positive, because as Prasad was saying, he is not, and you also said that you are more okay for using it in TNBC. So, in the setting of ER positive, once you've failed your CDK4/6 and even alpelisib, if the patient was, PIK3C, where is eribulin in your, ER positive domain?
Well, Shyam, conventionally, eribulin has not been the first choice chemotherapy for ER positive disease. The first choice disease, as you rightly have said, is taxanes, and more on a weekly setting or whatever it is, be it paclitaxel or nab-paclitaxel. But when you give a given scenario where the patient is having pre-existing neuropathy and other related causes because of comorbidities, I would not hesitate to bring eribulin forward, a drug which has got less neuropathy, forward, because the drug will be equally effective. And Professor Twelves has clearly shown that conventionally we were more inclined to capecitabine, but the data is on the contrary, showing that eribulin has a better overall survival than capecitabine. So I think it is time that we change our practice depending on this data. And I would definitely like to bring that drug forward if I have got contraindications for using taxanes in the first line.
Right. So I think you sort of made a very pertinent point. And actually, the patients also want to go easy on oral therapy, which is, domiciliary treatment. They don't have to make frequent visits. So, that also, weighs on the mind of the physician and the patient. But then I think we also have to look at the data, as has been shown in, 301 and other studies, that, eribulin is certainly easy on the patient, in the sense that it's a simple couple of minute injection, and then patient has to make brief visits to the even actually to the outdoor, not even the daycare admission is required, to my mind. Dr. Vishwanath, so what about HER2/neu positive? Have you ever used eribulin, in a patient who perhaps, can't afford expensive drugs like pertuzumab, and where, taxane and Herceptin has failed? So are you a proponent of eribulin there?
Sir, I have not used, but the data which Dr. Twelves showed, including in HER2 low disease, except for the ones who had like a totally ultra low disease, I think there was benefit which was seen with the use of eribulin. So I think it may not be a bad partner drug to think about, especially in patients who are not able to afford this highly expensive HER2 targeted therapies.
Hi, Shyam. This is Ashok Vaid. Can I make a comment here?
Please do.
So I fully agree with the usage of eribulin vis-a-vis the early line versus the late lines. We had an abstract in the recent ASCO. This is the real world experience of about 86 cases. And the two subgroups you mentioned, the HER2 positive and the triple negatives. So we have used it in alone as well as with capecitabine. So three things which we learned out of our experience, that it is a good drug in the HER2 positive and the triple negatives. And number two, it should come in the metastatic setting as early as possible. Don't delay using the drug too late.
Right. I think that is the point being made in this particular session, focusing on eribulin. So Dr. Prasad, are you happy using eribulin if somebody is not able to afford pertuzumab and Herceptin needs to continue as
I have used eribulin with trastuzumab.
Okay, and you won't hesitate using it in future as well.
Yeah.
So Dr. Twelves, any thoughts on the HER2 positive subgroup regarding the partnering with eribulin?
No, I'm interested to hear what the colleagues have said. We don't usually use eribulin in combination with trastuzumab in the UK. And I think that's largely because, for understandable reasons, the clinical trials simply hadn't focused on this group. And I think a perception has arisen that, what's the phrase, that there's absence of evidence, but that's not evidence of absence of benefit. And most people, I think, are not familiar with Linda Vadat's study from several years ago. There are also some real-world data from, I think, from Russia, again showing efficacy of the combination. So I think that there's not only is there no good reason to think it wouldn't be a good combination, the data that there are suggests that it is indeed a good combination to consider. And it strikes me as
Professor.
I'm interested. I'm interested to see. I'm aware that colleagues would be more inclined to use capecitabine with trastuzumab than eribulin with trastuzumab in some cases, and I don't think there's any good reason to support that.
Okay, so could you, I think, spell out your thoughts again on HER2 low and vis-a-vis eribulin? Is this because we don't have the deruxtecan available and it's so very expensive? So would that drug score over the other chemo drugs?
I think what this shows is that across the spectrum of the HER2 positivity, that eribulin is the more effective agent, as indeed shown by the forest plot that you have here. What we attempted the reason we did that particular study was really just to reassure people that there is benefit in the HER2 low patients, and that we needn't be sidetracked. I think now there are other agents, trastuzumab deruxtecan, will be, is getting approved in many countries. But I think after trastuzumab deruxtecan, then again, eribulin is going to be one of the favoured chemotherapies, and I suppose this again is the same story as with the other molecular phenotypes. Very often the targeted therapy will be the preferred therapy first or second line, but then beyond that point, I think eribulin needs to be closer to the top of the pile of the options that we have across the spectrum of molecular phenotypes.
Shyam, once again.
Yeah, sure.
I think in the interest of time, we may have to request you another five minutes. Another 5 minutes.
No. So I think I'm just finishing it up here. Final thoughts on Dr. Chanchal, visceral disease and non-visceral disease. Any takes there from any of the panelists? Chanchal?
Well, Shyam, I think eribulin is one of the most effective molecules, whether it's a visceral disease or a non-visceral disease. It's a drug which can be very easily administered. Unfortunately, it has not been used to its fullest potential because it has come in subsequent lines. Rather, as Ashok said, it should be brought up front. Professor Twelves has also enumerated on that. And apart from all these things, apart from the HR positive and triple negative, even in HER2 positive, Shyam, I would like to say that because the dual antigen antibody combinations are so expensive, the TBM1 are so expensive, if you want the philosophy of using trastuzumab and changing the chemotherapy backbone, absolutely suits, because you can use this drug, which is a day 1, day 8 schedule, and you can carry on with weekly trastuzumab along with eribulin. So if you have used taxane or if you have used vinorelbine, you can easily use eribulin with trastuzumab. And I think this drug should get more use in metastatic breast cancer. That's what I have to say.
Right. So I think we are over time. So I think the recurring theme, which I can understand from all the panelists and Professor Chris Wells, is that eribulin has a different mechanism of action from taxanes and works better if you were to use, immediately after the usage of taxanes, or patients who have been exposed to taxanes, and patients who have visceral disease, who have more than even 2 organ involvement. So the earlier you use this drug, I think the better the results are going to be. And we are fortunate to have the the cheap version or a cheaper version of the drug with us. So I think we should use the drug to the full and give the maximum benefit to our patients, just because it is so easy to administer. And as I said before, patients don't need to be hospitalized at all. So with this, we conclude this panel discussion. Thanks to the organizers, and over to Dr. Ashok for the next topic.
Thank you, Dr. Thank you, Dr. Sham. Many thanks to Professor Chris and equally to you, Dr. Sham, for the wonderful moderation. Professor Chris, it would be a great opportunity for us to have you in person as soon as we could. And we really enjoyed your talk. Thank you very much.
Thank you. Thank you for the invitation, and thank you for interesting discussion. And it would be very nice to meet face to face in the future. Thank you.
Our pleasure. Thank you so much. And we move on to the second panel discussion, which is the case-based panel discussion number 2 in the setting of ER positive, HER2 negative breast cancer. And I invite for the case presentation Dr. Daniel and moderator Dr. Krupashankar. Over to you. Thank you so much.
President.
Introduction slide. So Dr. Daniel is Associate Professor Medical Oncology at the Sri Ramachandra Medical College and Hospital for Chennai. Over to you, Dr.
Good afternoon, one and all. I thank the moderator for being here with me. He's one of my very good friends. I thank the organizers for this wonderful opportunity. And I thank all the senior professors who have given me the opportunity today. This is a very interesting case. Back in our city, it's a 28-year-old premenopausal woman who's got hypothyroidism and who delivered her first child in June of 2021. She had an LSCS, and postpartum, she had a mass in the left breast.
Slides are not moving. Yeah. Yeah.
Yeah. And therefore, she was investigated, and she was initially thought of as having had an abscess. A couple of trials with antibiotics was done, and a couple of FNACs were done, which was non-contributory. Meanwhile, on examination, the left breast showed a firm to hard central quadrant mass, which had erythema and enlarged axillary lymph node. It more or less kind of looked like an inflammatory breast cancer. So another core biopsy was tried. This time it favored invasive mammary carcinoma with ER positive and PR negative and HER2 negative. The Ki-67 was 65% and Aldrich score of 5/8. It had around 10 to 33% of the cells with ER positivity, and the staining was kind of intermediate with a score 2. We had a PET CT done for the sake of staging workup, and it did not really give us any mass. There was no discrete mass, but there was increased uptake in both the breasts. MR mammo was done, contemplating that this at least would reveal a mass, but MR mammo also did not show any mass. Only left axillary lymph nodes were seen. There was probably a collection of fluid. So eventually we have staged her as clinically T3N1M0 luminal B breast cancer on the left side, and neoadjuvant chemotherapy with 4AC was given from November 2021 to Jan 2022. Thereafter, the surgery was done, left MRM with axillary lymph node dissection in February of this year. The histopathology came out as YMP-T1B, multiple small lesions, the largest being 7 millimeter. It confirmed the same HPE. So this was the image that was taken pre-op. The slide is not moving. Could you just, yeah.
So the diffuse increased uptake in the PET without any defined mass and axillary lymph nodes. And in the mammo, there was a collection of fluid which is seen in that image, and the histopathology. Now, in the adjuvant setting, 4 cycles of docetaxel and EBRT was given, and tamoxifen was started on from July to 2022. In September, within a matter of 3 to 4 months, she developed headache, and an MRI was done for the brain and the spinal cord, which showed leptomeningeal disease, which involved up to L1 of the spinal cord. So there was a lot of discussion about her in the multidisciplinary tumor board. We opted to give methotrexate, but for some reason it was deferred, and CSI was given, craniospinal irradiation. After one fraction, patient did not tolerate. She threw bouts of seizures. She was comatose. She was in the ICU for 1 week, and she had to be stabilized, and after which another IT methotrexate was given, which kind of stabilized the disease. She gained back a consciousness. Her GCS was around 13/15. Now her ECOG is 3/4. Alternatively, she goes into kind of suppressed consciousness. Now this is the MR. Can you just move the slide, please? Next one. Yeah, this is the MR spine, which showed involvement up to L1. So now the caveats here in this case is that, number one, as we all know, lactating breast cancer, most of the times we don't see the PET-CT pick up any lesion. So we thought that MR is going to contribute. Even that did not contribute. So that is one important point here. The second is, histopathologically, when we did the core biopsy, we all know that the aggressive tumors are triple negative breast cancer and HER2. But this ER positive and PR negative group also seems to be a little deceiving in terms of the kind of its behavior. And so my thought is, should it be considered as equivalent to triple negative breast cancer in terms of its aggressiveness? If so, should we have incorporated a complete neoadjuvant chemotherapy prior to surgery? The next question is, if this ER is to be considered as positive, should we have added tamoxifen along with ovarian suppression?
Again, slides are not moving.
Could you just move the slide, please? So could this ovarian suppression, in addition to the tamoxifen, might have averted or maybe delayed the progression of the disease? And also the relevance of BRCA test and the PDL1 in this kind of a setting, with the relevance of ESR1 mutation. Next slide. And also being that the fact that this patient was not economically so sound, I mean, she really could not fend for herself. So if at all she could, what would be the role of CDK4/6 inhibitors or the role of PDL1 blockers, immunotherapy, or PARP inhibitors if a BRCA mutation was present? I would hand over for discussion to my real friend and brother, Dr. Kripa, and he would take this over.
So a very good afternoon and a warm welcome to everyone. And at the outset, before I begin, I'm going to take this opportunity to congratulate the organizers and Vaid sir for putting together this wonderful academic initiative, and also thank them for the opportunity. So I think we can call out the panelists. I'll probably introduce the panelists as well. Dr. Ajay Yadav, medical oncologist, Jaipur. Yep. Can we have you on stage? Thank you. And Dr. Suresh, medical oncologist from Chennai VS Hospital. Can we have you on stage? And Dr. Nirmal Roth, can we have you on stage as well, sir? Or should I introduce you as the oncologician or from Twitter? Good to have you with us today. Slides. All right. So I think the stage has been set for us by my real close friend and someone who I look up to, Dr. Jovita Martin, who's actually, set the stage for this panel discussion. So first thing I decided is when it comes to hormone receptor positive disease, I didn't want to talk about metastatic disease alone, because that's something that gets discussed every single day in and day out. And it's all about CDK4/6 inhibitors. So let's see what else we can discuss apart from the CDK4/6 inhibitors. My first question probably is, how do you look at defining pregnancy-associated breast cancer or gestational breast cancer? How different is that from the normal breast cancer that we get to see in practice? Dr. Ajay, I'll begin with you.
Pregnancy-associated breast cancer, usually they are aggressive tumors, and usually they are diagnosed in advanced stage, probably LABC or metastatic disease.
Okay, fair enough. I think the timing is also pretty important, because anyway, it can happen during pregnancy or even up to 1 year postpartum or some during lactation as well. So that's how we look at defining it. And less than 30 years, the incidence is pretty high. It's up to 20%. And as with advancing age, definitely the incidence starts declining as well. And definitely a higher incidence of BRCA mutation, they tend to present with advanced disease and very aggressive disease as well. And there is higher incidence of inflammatory breast cancer. And we've seen all that in the case which Dr. Chavita actually presented as well. And the interesting thing here to note as well is the incidence of ERPR positivity, which seems to be much lesser when compared to the general population. So only around 25% have ERPR positive disease as opposed to 55 to 60% in the general population. So over to Dr. Nirmal. So, in practice, what are your indications for testing, genetic testing? Do you do it for all patients? How do you do it in practice? I know, like anybody with a diagnosis of breast cancer, now if you look at the current ESMO or the ASCO recommendations are to offer genetic testing for everyone across the board. But is that feasible in practice, and how do you do it in practice?
No, usually I do it for age less than 45 years, right, to all the patients of breast cancer, or age 45 to 50 if there is another second breast cancer in the family, or a family history is there. And if the patient is with triple negative, then we can go up to 60 years, then we can test. And any age, if any of the population which is at high risk.
Absolutely. I think, that's what I think we need to be judicious in practice as well. Male breast cancer, bilateral breast cancer, somebody with young age, less than 45 years, or somebody with a family history of malignancy, and especially triple negative breast cancers, because we must remember that in India, it happens about a decade earlier. We don't, median age of onset of breast cancer here starts at 40 years. It's not 50 years or in the fifth decade as in the Western countries. So it's very relevant for us to offer genetic testing, at least in this high-risk subset. And what about using any online tools to actually predict their lifetime risk of developing breast cancer and then actually offering genetic testing as well? Dr. Suresh, your thoughts on that? We have any number of online risk models as well, like the Gale risk model. And then, we have the Klaus et al. Model, and then the Taylor-Kuzak model as well. So what your thoughts on, probably telling the general population, why don't you check yourself up for your lifetime risk of predicting breast cancer and then getting yourself screened? Can that be done? Or am I being too ambitious?
No, that may be too ambitious, because whenever they go in for the internet, most of them are half-baked things. So the understanding may be very different from what has to be taken. So each and everything they'll be getting afraid of things, and then they'll be going on testing. Then there will be the other extreme where they don't even go for the internet studies also. So we should be, as a clinicians, when they come to us, we should be guiding them when to do and how to do. So that's
but I think it's probably part of our duty as well to probably create more awareness about these sort of things, because we have something called the BRCA Pro score as well. But the problem is, like you rightly pointed out, not many of our patients actually are aware about it. But we call it the pica syndrome. Pica, we all know, is an eating disorder, but it's also called the parents parents India and children who are abroad, pica, and PICAD, pica D, where parents in India and children abroad who are actually doctors. So they end up grilling you with questions if you actually don't do all these tests as well. So while we're at it, we'll probably get your panel's thoughts on this as well. So we know now that the Oncotype DX has actually been made part of the AJCC staging system. So how do you look at that, Dr. Ajay? And is that practically feasible again in the sort of setting where we practice? Is it practically feasible for us to do genomic testing for everyone with hormone receptor positive early breast cancer, even to stage them actually?
No, not for all. It is very difficult to do.
So, Dr. Nirmal, your thoughts as well on that. Do you see that as just a commercially driven by the Genomic Health Sciences Laboratory in the
Yeah,
US?
because the cost is so massive that the patient will prefer completing the chemotherapy rather than taking the test.
Absolutely.
So that is why I don't think it's practical.
Correct. I think that's probably the biggest caveat of it, and probably something which we can't really afford to do for all of our patients in practice. So moving on, if at all you had to do a genomic testing, what would be your preference of a test? Would you do the the Indian-based scan assist, or is it the Oncotype DX, MammaPrint? How would you look at doing that, Dr. Suresh? How would you pick your genomic testing? Let's say you have a patient who has hormone receptor positive early breast cancer, and you're looking at probably trying to avoid chemotherapy. Patient is not keen on getting chemotherapy. So no financial constraints. So let's keep the finance
less
out
than
of this.
50, I go for chemo. I don't mind about doing this, even though the recommendations are that.
Okay.
And in less than 50 years, yes. I don't.
Even in the node negative subset.
Yes, I don't want to take a risk in this young age.
No, but let's say patient is very keen.
Yeah,
Wants
keen
to
in the
avoid
sense.
chemotherapy
Yeah.
at all costs.
But generally, I try to tell them. But above 50, yes, that's where I will be keen to avoid chemotherapy and tell them what are the possible things. And coming to MammaPrint, which might cost around 3 lakhs, and then we go with Indian Canon Assist type, which can be less than 50 also when we speak to them. But the real value, whether it's approved by FDA and whether we can be taking up as a treatment protocol, we have to think twice. Unfortunately, in India, we don't have much of, my practice at least, we don't have much to go for this thing.
Yeah.
Most of the patients are coming up in advanced stage.
Fair enough. But I think given a choice, I think, if you had a choice and if a patient did not have any financial constraints, I'm sure we would want to offer this to our patients.
Yes.
Because just look at those numbers. That's very impressive. About 70% of patients with early breast cancer can avoid chemotherapy, especially if they're node negative, irrespective of their menopausal status as well. So that I think is probably where it's really making a difference. And so again, you spoke about the cost. So Oncotype DX is around 3 lakhs, agreed. MammaPrint is around 1.5 lakhs. And like you rightly pointed out, Canvas is around 50,000. So, and we know that MammaPrint probably, what are the subset of patients where you would actually look at getting a MammaPrint done? Because, yeah, Dr. Nirmal.
The ones with node positive, I would 1 to 3 nodes would go for MammaPrint.
Correct. So I think, that's one of the, the MindAct study, which looked at the microarray analysis in node positive and node negative patients to avoid chemotherapy. That's what MindAct stood for. So, when you look at it, the clinically high risk group, around 46% who are actually clinically high risk can avoid chemotherapy, because we always talk about the genomic risk overriding the clinical risk. So I think that's another point. And you only have high risk and low risk. You don't have an intermediate risk at all as far as MammaPrint is concerned. And what about node positive disease? Now with the RxPonder data coming in as well, Dr. Ajay, your thoughts on the RxPonder data and probably doing it even in patients who have 1 to 3 nodes positive or N1 disease, if they're keen on avoiding chemotherapy, premenopausal versus postmenopausal, how do you look at doing it in practice, Ajay?
Okay, we are not doing routinely in selected cases, as you point out, that the patient is willing, then we advise in selected patients.
Fair enough. So I think probably the take home should be that in premenopausal, if they have node positive, you cannot avoid chemotherapy, because there is a definite benefit of chemotherapy. We can always argue about whether it's the chemo-induced menopause that's actually making the difference, or could OFS, actually overcome that benefit. But that's again up for debate, which is probably what we're going to look at in the next slide. But for postmenopausal, even if you have node positive disease, even 1 to 3 nodes, you could definitely look at offering, especially if the patient is keen on avoiding chemotherapy, you could still definitely do an Oncotype DX in those patients. So again, Dr. Nirmal, back at you for this. So this was the RxPonder, the study alone, when they looked at chemo followed by endocrine therapy and endocrine therapy alone. So how do you relate that? Probably, if the control arm had endocrine therapy plus OFS, could the results have been different? Because I think they all attributed it to probably chemo-induced menopause or the ovarian function effect from chemotherapy actually leading to the benefit that was seen. But I think probably in your case, if at all you have a patient who's very keen on avoiding chemotherapy, would you say, okay, OFS plus hormonal therapy is probably an alternative here in that sort of a situation.
Yeah, I think OFS plus endocrine therapy would suffice.
Would be an option as well.
Yeah.
Correct. Even though we don't have the data to actually suggest that, yes. And this is very interesting. This was an editorial that came up. We all keep talking about precision medicine and being very personalized therapy and all of that. But what is the precision of evidence needed to practice precision medicine? So again, this was one of the drawbacks with the Oncotype DX test as well, which looked at only the genomic risk factors. So how about incorporating the clinical risk factors into it as well? So that's where the RS Clin comes in, which is the clinical score, recurrence score for clinical assessment as well, which incorporates the clinical high risk factors as well. So Dr. Suresh, back at you. How do you look at doing that? I mean, like, I know, whenever you order for an Oncotype DX, if you do get an order for an Oncotype DX, this data doesn't get incorporated into that reporting system. So how do you then look at deciphering it in addition to this data, and how do you console a patient? Because even after doing an Oncotype DX, if you're less than 50 years, and if your recurrence score is within 16 to 25, there is still about a 6% benefit from chemotherapy. So you still can't tell them, after ordering for such an expensive test, that you're still undecided about it. So how do you look at this, and how do you look at the addition of clinical risk as well?
So if there is going to be an grade 3 thing, or if Ki67 is more than 20, because sometimes we might have it in the ERPR head to Ki67. So if these two things are there, I would be suggesting to go ahead with chemo, even if the risk score is in between.
So, and the other thing probably that I'll ask Ajay as well. So Ajay, let's say you have a patient with a 0.8 centimeter tumor, right? T1B. Would you order for an Oncotype DX there?
Yeah.
Or what should be the cutoff for the general for everyone here to take home as to when you actually order for a genomic testing in practice?
So size between 5 to 10 mm. That will be the cutoff. For 0.8, okay. It will be the ideal case for this test.
Correct. So anybody with tumor size more than 1 centimeter, as T1C onwards, you can definitely do it irrespective of the grade. If you're doing from 0.5 onwards, only if it's grade 2 or grade 3 you need to do it, and less than 0.5 you cannot order for it. It doesn't make sense because the inclusion criteria for the trial looked at only these subset of patients. So I think that's very relevant for us to take home. And this is what I was trying to highlight earlier as well. Look at it. Even if you have a lymph node positive disease, we've already seen that premenopausal you cannot avoid chemotherapy. Postmenopausal, yes, you could still avoid chemotherapy if they have a low recurrence score. But the 16 to 25 is where you get caught, even if they have lymph node negative disease, if they are premenopausal. So there is around a 6% benefit, even if they have low clinical risk, which is where you could also discuss ovarian function suppression plus hormonal therapy as an alternative. So again, this we've already seen. I've already spoken to you about when we should actually get a genomic testing done. Okay, this is interesting. What should be the poor man's? Since we always keep talking about finances in India, India being a low middle income country, and most of our patients cannot afford to do it. So what then should be the ideal poor man's Oncotype DX? Should it be the Ki67? Should it be the Oncotype DX? The CAN assist I meant, or do you just use online tools for calculating the Oncotype DX? Dr. Nirmal, I'll probably begin with you.
So for me, for poor man's Oncotype DX, I use Ki67 as a cutoff. So if Ki67 is low, then I would give only endocrine therapy. Right. And if it is high, then I go for chemotherapy. And the second question was?
What about IHC4? Anybody, in the house as well routinely doing IHC4 analysis?
Okay. So we don't call it IHC4, but we call it ERPR and HER2 and Ki67. Correct. So all four are given by the pathologist.
Just there a small difference, like when you look at only Ki67 alone separately, there's a lot of tumor heterogeneity. So if you hit different parts of the tumor, you're likely to get different values of Ki67. Yes. So the IHC4 is basically a semi-quantitative information based on a mathematical algorithm, which actually tells you, and that's probably why it's slightly better off than only the Ki67. And this is the CAN assist. I know we've already spoken about this multiple number of times. It's an IHC based testing, which does incorporate also the clinical risk factors like the tumor size, grade, and nodal status also. So I think that's probably one of those advantages here, when you compare it. And let me tell you, there is real world data where they have looked at comparing it to Oncotype DX. There's about an 80% concordance with CAN assist. That's been published as well from India. So definitely a valid option if you're looking at cutting down on the cost. This is around 60K if you order for this test, and the turnaround time is only around 10 days. But what about using online based tools? I think that was probably the most important part of it. There's something called Maggie equations, which has been a lot of work done on it from the University of Pittsburgh Medical Center, UPMC. So it's basically you have to know the HET score, so the histological score based on the percentage of ER staining and the PR staining, and then you with the help of your pathologist you can actually calculate this, and again I mean like you could predict. Again, this also has a concordance rate of around 80% with your Oncotype DX. So these are all, I'd probably call this the real poor man's Oncotype DX if most of our patients can afford it. So moving on, again in the case that was just presented by Dr. Jovita as well, you know, pregnancy-associated breast cancer, and a patient is, you know, probably lactating at that point in time. What would be the best chemotherapy regimen? Should it be dose-dense chemotherapy? Any choice, Dr. Ajay?
For selected patient, dose-dense chemotherapy. In young patients who can tolerate the chemotherapy, and educated patients, a patient is from rural background and he can't come for febrile neutropenia frequently, then I will avoid this dose-dense also.
Okay.
Standard 3 weekly AC followed by taxane.
Okay, so taxanes, what is your preference of taxane and how often do you use it?
Paclitaxel I usually prefer.
Okay, and how many, like, what is your frequency at which you use it? The dose intensity, that is?
3 weekly.
You're using 3 weekly. Anybody else using 3 weekly paclitaxel here, Dr. Suresh?
No, I go for 3 weekly dosing.
Dosing, okay. We'll get to that as well, but again, we'll get Dr. Nirmal's view as well, Dr. Nirmal.
No, I go for weekly pacli.
Weekly paclitaxel. Ashok sir, we'll get your thoughts on that. What do you do, sir? I mean, like in practice.
So Pacli is better as a weekly and then Dosi as a 3 weekly. The intracellular retention of Pacli is shorter. It's always a better.
So you're alluding to the ECOG E1119 trial as well, which looked at comparing these 4 regimens.
Absolutely.
Weekly versus 3 weekly.
But there is a caveat, you know, patients coming from a little distance away, even 2 weekly dose dense is not a bad idea actually.
True. Correct. So like you rightly pointed out, so I think 3 weekly Pacli is out. It either has to be 3 weekly docetaxel, as Dr. Suresh pointed out. But then the problem with doing 3 weekly dose is that it has to be 100 mg per meter square. And none of us do that in practice. We rarely go beyond 75 milligram per meter square. So, and that's how the trial was actually looked at.
I think there is a little bit of a learning from the Japanese. Japanese never accepted the dose of docetaxel what the Western world said. And their dose of docetaxel is 60 milligrams per meter square. They did their own studies.
True.
And then they never accepted 75 and 100 as the standard dose.
Exactly.
So Indians could actually learn from, you know, take a leaf out of their experience.
Absolutely. Like you rightly pointed out, I think we could also, you know, look at trying to take a leaf out of their book. I know people, you know, these days with TikTok and all, there's a lot of talk about Japanese data being hacking into ours and all of that. But I think we, you know, it probably is better if we do it the other way around as well. So yes, so probably weekly. Yeah, sure, sir, please.
I think what we are discussing is absolutely right, that weekly taxane is much better, preferred, tolerable, ease of administration. But Dr. Ajay and me are working together in a setup in Rajasthan where 87% population has got a health insurance that is provided by the government.
Sure.
So the insurance policy doesn't allow us for weekly. The next schedule can be only after 3 weeks. So that becomes a very, very important practical point, in fact.
Very true. Very. I mean, like you said, that's a very valid point. Even in Tamil Nadu as well, we have the Chief Minister's Comprehensive Health Insurance Scheme, which doesn't allow us to give dose-dense chemotherapy. But I think probably the take-home is that if you have somebody in your practice who can afford the cost of therapy, then I think it should be either weekly or 2 weekly, depending on your convenience, because that has shown a survival advantage as well. So that should be the take-home. Sure. And the NCCN guidelines also seem to reflect on that. It's actually sequential anthracyclines and taxanes. Taxanes, your choice of taxanes, either weekly or 2 weekly. There was a comparison again done with weekly and 2 weekly paclitaxel. Weekly, the tolerance was much better. Incidence of neuropathy was much lesser with weekly as opposed to 2 weekly. Myelosuppression was more with 2 weekly. So that's a caveat. And dose is 175 milligram per meter squared. Weekly pacli is 80 milligram per meter squared. What about anthracyclines? Can you avoid anthracyclines? At least in early breast cancer. What about TC into 4 or TC into 6? Again, Dr. Nirmal, I'll begin with you. This is the ABC meta-analysis, the anthracyclines in breast cancer that was looked at. So in your practice, if you have a patient probably with early breast cancer, you're looking at avoiding anthracyclines. Are you comfortable doing 4 into TC or 6 into TC?
Yeah, when early breast cancer, I can avoid anthracycline. Yes, definitely.
And your choice, how many number of cycles?
4 cycles.
Four
Yeah,
cycles.
yes.
Dr. Suresh, any takers for 6 cycles?
No, in early breast cancer, I would stick to 4.
Okay. So let's say, for example, you have somebody with a locally advanced breast cancer. You cannot give anthracyclines for some reason. A patient has a cardiotoxicity, prior existing cardiotoxicity. You cannot give anthracyclines. In that sort of setting, you're doing TC. Would you still stick to 4 cycles? Would you give to 6 cycles?
I'll give 6 cycles in that cycle.
6 cycles. So fair enough. I think, again, the ABC meta-analysis as well, only the US Oncology Research Group was a positive trial. The other 2 NSABP trials were actually negative. So the overall meta-analysis proved that they could not show the non-inferiority of TC compared to AC and taxane, but nevertheless remains an option in the node-negative subset, and that's what is being highlighted here. And this was another very relevant point which Dr. Jovita mentioned during her case presentation. So if you have somebody with a low ER expression, how do you look at approaching them in practice? How do you treat them in practice? Let's say ER is low positive, between 1 to 10%. PR is also negative or low positive. Do you still treat them as hormone receptor positive, or should you treat them as triple negative breast cancers? Dr. Ajay.
No, we are treating as hormone receptor positive.
Even for those low receptor positive subset?
Yeah.
Okay. Dr. Suresh.
No, though we take it as a hormone positive case, we, at the back of the mind, we know that they are going to fail very fast.
Correct. I think that's a key point, Dr. Nirmal.
Yeah, we take it as negative and treat it as triple negative. Yeah.
So I think I would also agree with that, because the case which Dr. Jovita had also rightly pointed out had PR negativity and only ER positive disease, and we don't know about the strength of ER expression. If it was low positive, I would have probably treated that patient as a triple negative breast cancer right up front. Because even if you look at the
67 of 65%.
Exactly, correct. So, I think that's a food for thought. And again, even if you look at the soft and text analysis as well, they took a cutoff of more than 10% for inclusion as part of inclusion criteria into their trials. So it makes sense for us to do that. This is something that we all know: tamoxifen 5 years, 10 years, the Atlas, and then the ATOM trial, then the switch strategy with the MA17R trial, and then the ovarian function suppression. So I'll just quickly get onto that. We're not going to get into this. So let me just quickly ask the panel. So who are you going to consider a switch for? Would it be the perimenopausal subgroup of patients alone?
Yes, sure. Perimenopausal patients, we would go for a switch therapy.
Switch. And how long do you actually wait before you switch? Is it 2 years, 3 years, or?
We give tamoxifen for 5 years and then
switch
off to.
Any takers for 2 to 3 years of tamoxifen and then switch?
Yeah, if it's going to be more than 40 years of age, then chemo-induced amenorrhea and the patient is having a CAA for 2 to 3 years, I'll switch over.
You will switch over. And probably we'll have to look at the FSH, LH, and estradiol levels as well to make sure that they're within the postmenopausal range, and then probably look at switching over. Fair enough. And this is something that, I probably should be discussed. What is the risk of reversal of chemo-induced menopause when commencing on an AI directly? Because, sometimes we look at patients, okay, fine, patient has got chemo-induced amenorrhea. Right, fine, let's put them on an AI. But then the caveat is that about 30% can actually resume menstruation, and then that's when it can all go wrong. So if you're contemplating doing that, I think ovarian function suppression is a must. Choice of ovarian function suppression can vary from individual to individual. It could be either lab BSO or it could be ovarian function suppression with GnRH analogs. That's fine. So soft plus text in your practice, what would you do? Who would be the ideal patient who would go on ovarian function suppression? Dr. Suresh?
Any patient less than 35 years who will be having a high risk of getting their menstruations once we stop the chemotherapy. So these are the patients I would be preferring to have an OFS when they start a hormonal treatment.
Okay. Dr. Ajay, in practice, is it only the age for you, or any other factors that you would look at?
No, any patient having menstruations, I would not rely that when chemotherapy, we start chemotherapy and patient become amenorrheic, we don't consider them as amenorrheic.
Sure. So I think, age less than 35 years, high grade disease, grade 3, node positive disease, and patients who have received adjuvant chemotherapy, these were part of the high risk criteria looked at in this trial. But then again, the problem with that is adjuvant chemotherapy is because they routinely do genomic testing in their practice. So their indications for adjuvant chemotherapy is actually much different from ours. Here in our practice, if patients cannot afford a genomic testing, we actually tell them to at least take 4 cycles of TC. So we do that in practice. So I think that's probably one of the caveats here as well. And have any of us actually used this risk app to look at to look at gauging the benefit from ovarian function suppression? So this is the composite risk app, which is again an online based tool, which will help tell you the composite risk score of adding ovarian function suppression to your patients. So that's something which can be done. And how long would you want to continue the ovarian function suppression? I think that's another key question. Dr. Nirmal, your thoughts on that? How long do you continue it, if at all you offer ovarian function suppression in your practice?
So ovarian function suppression, we would continue until the patient has amenorrhea. So when the patient achieves amenorrhea, then we would stop it.
Okay. I think the often the text looked at continuing it for up to 5 years. So I think fair enough that we actually look at doing the same if you're following the same strategy, that is. And again, there have been any number of trials looking at fertility preservation or preventing premature ovarian failure with the addition of GnRH analogs as well. The POEM study, the SWOG meta-analysis as well. So that's another indication for us to start them on ovarian function suppression as well. So any takers for this extended hormonal therapy, extended AIs, Dr. Suresh? Would you stop at 5 years, or is there any subset where you would look at continuing it beyond 5? The SALSA study again. SALSA is a dance, but then that was the ABCSG study that was called SALSA. So 7 years, 5 years, or 10 years?
Yeah, 10 years. This MA17 studies shows that even with 10 years we can go. But there was some studies like we do an endopredict and prosigna after 5 years to see whether they are going to have a benefit or they are going to have AI-induced complications out there. Correct. So depending on that, we can take a call.
So the only issue with the MA17R study is that majority of the patients had actually received prior tamoxifen, and then they went on letrozole for the next 5 years. But then for one positive trial, you had a host of negative studies. The NSA BP42, DATA, IDEAL, all of them were negative studies for extended hormonal therapy. And then came the SALSA study, which looked at 7 years. Is probably an alternative. And we could use an online tool called the CTS score, the Clinical Treatment Scale Score, which takes into account 4 parameters: age, nodal status, tumor grade, and menopausal status. So if you have all those parameters, that will again predict your risk. And for those who fall into the high risk, you could contemplate an adjuvant extended therapy for up to 7 years. And again, if you're doing ovarian function suppression, any takers for doing exemestane plus ovarian function suppression? Because that was also looked at. Or would you still say only tamoxifen plus OFS, or any takers for AIs plus OFS? Because anyway, you're doing OFS and you're making them postmenopausal. So why not give them the benefit of both? Any benefit with that? Or are you going to stick with tamoxifen and OFS? Dr. Nirmal?
Yeah, tamoxifen plus OFS.
Tamoxifen.
Yeah.
Dr. Ajay? Yeah. You as well. Fine. So I think, this was again the EBCTG meta-analysis, which showed that there was only around a 3% improvement in just the recurrence-free benefit and breast cancer mortality. Overall survival didn't still seem to change. And also you had to account for the adverse effects of continuing with AIs. As Dr. Suresh rightly pointed out, the osteoporotic fracture risk, musculoskeletal symptoms, high risk of cardiovascular disease, all of that needs to be factored in. And this is the CTS5 that I was just discussing about, the tumor size, grade, node, and the number of nodes involved, which takes into account all of these parameters and tells you what you could do. And again, like Dr. Suresh rightly pointed out, there is the BCI test, the breast cancer index test, that can also be done if somebody falls into the high risk category. Again, you're looking at giving them an adjuvant endocrine therapy for a longer duration, for up to 7 years. Before we conclude, adjuvant CDK4/6 inhibitors, yes, no, in practice? We'll begin with Dr. Nirmal.
Yes.
Okay.
For high risk cases, I would definitely add a CDK4.
Okay, you would. Given that again, we had a couple of negative trials, and I'll be different scenarios. Penelope looked at only patients who had adjuvant residual disease, and Palace and Monarch, similar trial design. But unfortunately, so was it only that the selection criteria was different, which is why probably the results are different? How do you look at that?
Yeah, because the selection criteria of the 3 trials were different, so that's why the results were different.
So just to throw in another googly here. So if you have a patient who has a germline BRCA mutation, would you do adjuvant? Still offer adjuvant abemaciclib, or go on to the Olympia data and offer them olaparib? Olaparib versus abemaciclib.
Olaparib.
Okay, now olaparib. So then, okay, Dr. Suresh. A young patient, germline BRCA mutation, and strongly node positive, more than 4 nodes positive, hormone receptor positive.
In patients, definitely give them a benefit for the olaparib.
With olaparib. Okay, thank heavens nobody said a combination of abemaciclib plus olaparib. So I think we're safe with that. So yeah, I think I'd probably agree with that. Biomarker driven therapy, if somebody's got a germline BRCA mutation, I think the benefit, even though the Olympia study only looked at around 16% of patients had hormone receptor positive, majority of them were triple negative diseases, more than 80%. But having said that, that's a caveat, but still, given a choice, I think PARP inhibitors would probably be a better option. Adjuvant bisphosphonates, we know that we all trying to do that, especially if we're giving AIs. once in 6 months for up to 5 years. So I think those are for the future. Could you look at CDK4/6 inhibitors replacing adjuvant chemo? And can we actually select patients that will benefit from adjuvant CDK4/6? And how do you choose between olaparib and abemaciclib is what we've discussed as well. So with that, I think we've come to the end of our panel discussion. I'd like to thank all my panelists for making it such an interactive discussion. Thank you so much, guys. And I'll hand it over back to the organizers. Thank you.
Thank you.
Thank you very much. And our next presentation is by Dr. Salil Patkar. He would be speaking again on metastatic TNBC. And I would like to request Dr. Avinash Pandey, Dr. Saurabh Mishra, Dr. Lalit Mohan Sharma, and Dr. Amit Kumar to come to the dais for the panel discussion. Dr. Salil, please. Hi. So thank you so much.
All right, shall we begin then? I'm going to talk about metastatic TNBC. The case has been provided. All right, so let's go ahead. 38-year-old woman was referred to a tertiary care center for an axillary mass. Physical examination shows a right breast mass and fixed and enlarged axillary lymph nodes. Lab test, normal range for tumor markers. Do we usually send tumor markers? Mammography, focal asymmetric density with cluttered pleomorphic calcification, USG done, irregular mass in the right breast with multiple axillary nodes that were enlarged and fixed. MRI, not really required, but breast MRI of 3 centimeter in diameter mass and multiple enlarged and fixed axillary nodes. So we do a PET scan. Would everyone here want to do a PET scan in this particular case? Yes, I think we'll all agree, a fixed large nodes enlarged. So PET CT shows a right breast mass, multiple axillary nodes swelling. Finding of distant mets is negative. Histopath examination done of the right breast tumor, invasive ductal carcinoma, IHC, and FISH of the tumor cells that start with IHC shows TNBC, ERPR, and HER2 negative. The nuclear grade 3 was recognized. So before we begin, how commonly are we coming across TNBC?
10 to 15% of the cases.
10 to 15% of the cases. That's true. I think everyone would agree. I think on around 10 to 15, maybe around 20% of the cases.
Yeah, around 20%.
20% of the cases. Okay, all right. So we have again TNBC of the right breast, ERPR, HER2 negative. What are the main challenges that you face practicing, treating patients who are TNBC positive? Dr. Avinash?
Yes, so I find these women generally are from the younger age cohort, and my percentage of patients with triple negative is more than 25.
More than 25, yeah.
That's so
you mean for the younger, younger
cohort
less than
of,
40?
Yeah, younger cohort of women, and then they present with a large mass with nodes, and often I find 15-20% of them having a metastasis to begin with.
So METs to begin with, younger age group, aggressive tumor. I guess we all agree with that. That is true. Anything else? Anything in particular?
In fact, I would like to point that not only this, but many times if they go to surgeons first, most commonly even in LABC surgeons do upfront surgery. So the neoadjuvant chemotherapy option we lose, in fact, and we don't have anything for response assessment. So that also becomes very important, that where the patient lands up.
Yes.
So many times based on FNAC alone, they do a MRM and 16 out of 20 nodes are positive, and this is T3 lesion and TNBC.
Absolutely. So in a room where there are very few surgeons, we can all agree it's a problem we all face. Entirely true. I've had patients where even the biopsy was done, the IHC was done, it is TNBC, and yet they would be operated upon. And not necessarily by local surgeons or general surgeons. I'm talking about even oncosurgeons doing that. But anyway, let's not get into that part, shall we? All right. So these are some of the problems. Anything else besides that? Any problem? Like a real true world problem. Most patients unfortunately end up being operated the minute they come. Besides that, younger, more aggressive tumors. Anything else?
They naturally present with LAVC. Most of
more commonly do present with LAVC. All right. So what are the top 3 patient and disease related factors that you have to consider? I'll show you the factors when we are dealing with TNBC. So amongst this, what would you say, Dr. Saurabh, what would you say would be your top 3 in this?
So obviously patient age is the first preference.
Right. For treatment selection.
Okay, and TNBC is already there. If it's a LABC, new adjuvant is the approach. So patient age is important. Performance status is also important. And I don't go for molecular features, nothing extra. And others, that's the organ functions basically.
Fair enough. So age, tumor burden perhaps, and anything else then, Dr. Lalit?
The site of metastatic disease is also important.
Could you emphasize on that?
Like visceral metastasis is more having, because they more commonly have more of visceral met rather than the bony mets.
So how would that influence your line of treatment, assuming that you have a patient with visceral mets?
Somebody may be having upfront, say, hepatic dysfunction or some pulmonary dysfunction. So again, in that case, it becomes difficult for us to sort of de-intensify the treatment. We need to be more aggressive
perhaps to begin with. Fair enough. Dr. Amit, your top three criteria in this while considering where to and how to treat
Surely the patient is, tumor burden, and the sites of mets. Liver mets are very notorious. Even if we treat, they are going to relapse very soon. So we have to be very aggressive in those cases of patient.
All right. So age matters to all, location matters to all. Performance status, of course, always important. So what are the goals of treatment? I think the goals of treatment we can all agree on. Everyone wants our patients to live longer and lead a good life, a non-complicated life, not too many side effects related to a treatment. Because when it is TNBC, generally we end up going aggressive. Another problem that we face with TNBC, like we just discussed, they're aggressive young people, is the lack of, at least up and until now, except for PDL1, the lack of any actual targetable, mutation or anything of that sort. So is there a survival advantage? Yes, treating the patient does have its survival advantages. If you go through hundreds of trials that have taken place to see the chemotherapy, of course, one of the problems in most of the trials is that they allowed for crossover, but certainly there is a benefit to treating the patient. We will start the patient on chemotherapy. Majority of your TNB patients will start with chemotherapy. The question is, I'll move on to that part. How will you proceed from here? Do you go for single agent chemotherapy? Is there any situation where you do consider for going for combination chemotherapy?
Surely, if there is a high tumor burden and if the patient is in something like a visceral crisis like situation, rapidly progressive disease, then surely combination therapy.
So rapidly progressive disease, high tumor burden, you'd consider for combination, and then that combination would be?
It could be anthracycline with cyclophosphamide, acirezine can be given.
All right, Dr. Lalit?
Or paclicarbo.
Yeah, so commonly I'm very much tempted for the platinum compounds.
Platinum-based compounds.
So taxians plus platinum remains first choice if it is a combination.
All right. So then again in TNBC, where that platin would be, would you wait for your BRCA or it is irrespective of the BRCA mutation?
In fact, without waiting for that BRCA,
you would consider for platin-based agent. Dr. Amit?
Yeah, surely we'll not wait for BRCA mutation testing.
All right. Everyone here in the panel would go ahead with platin-based as the first line of treatment for chemotherapy for TNBC?
For rapidly progressive, in combination one. Otherwise, taxane is the preferred. It's a single.
If BRCA report is there, strongly positive, I'll be more confident.
That's certain, yes. If BRCA is there, there is no doubt. That certainly holds true. Okay, so again, we are aware of these parts, various trials that went. I'll just summarize it. There is really no benefit shown with combination chemotherapy, but early as the panel has pointed out, if you have a disease burden which is very high, a patient who probably will tolerate the treatment well, and if the patient is in an impending visceral crisis, then yes, combination chemotherapy will work, but please remember that there is no survival benefit. We are only talking about a PFS benefit in this case. So selected trials where they have tried for sequential versus combination, again, all of them failed. They tried combining anthracyclines with paclitaxel, doxorubicin with docet, with doxo with pacli. But the final conclusion was that unless for that rare patient who will tolerate those kind of side effects, remember quality of life, very important when we are dealing with metastatic disease, it is not justifiable to consider for dual therapy. Now coming back to our case, first the patient was again a TNBC patient, was given AC 4 cycles for 3 weeks. Now I know we probably have dealt with the NACT part. 4 cycles AC followed by then paclitaxel weekly. Is everybody happy with this NACT regimen?
It could be a dose dense AC.
So one is dose dense, fair enough. We would have considered for dose dense. I agree with that. Anything else? Dr. Saurabh?
Response-based change of regimen can be seen. I don't know whether it has been response assessment was done after the 4 cycles.
Yeah, not my case, Mylan's case. So
Okay. So maybe sometimes when there is a non-responsive disease or less responsive disease, in second regimen we can add platinum.
So that's interesting. I
sometimes.
agree with that because I had a similar experience just yesterday morning. I'll discuss that one. But so again, dose dense AC. Besides that, anything else that people would want, anyone here in the panel would do differently? I agree with the interim eval part because I experienced that myself.
2 weekly regimen of paclitaxel is also okay. Dose dense.
All right, 2 weekly regimens of paclitaxel. I'm not. I generally go for weekly dose dense. But anything else? Anybody else in favor of adding platins?
In fact, in sometimes where we feel that the patient will not be able to go for second line, or where we feel that this is the last chance to treat these patients. So out of passion, we give taxane along with platinum upfront also in NACT and personal observation that these patients have better PET-CR rates.
So that is true. In fact, anyone else wants to? Yeah, please.
Have you anyone have done reverse sequencing?
Reverse sequencing has not really shown any per se benefit of.
No, in triple negative, basically when you want to use platinums upfront.
So again, it's not about, for me at least, I'll tell from my personal experience. One, that I agree with the panel when they say that platins can be considered because there are, again, this is not, we were to discuss TNBC, but just for the sake of discussion, even in NACT, there are 3 trials which dealt with whether platins actually help. There was the, I think, brightness trial, then there was an alliance trial and a third one. And if you look at 2 out of those 3 trials actually showed a benefit of adding platin. And they showed an improvement in the PAT-CR rate, which we do consider as a surrogate marker for OS. Now, the thing about the alliance trial was, so in that trial, what they did was their protocol was designed in such a way that if the patient developed neutropenias, they skipped the drug. They didn't delay the treatment. Now, even in those patients in alliance trial, where the patients who managed to actually take the cycle as per the schedule, the PAT-CR rate was really much better on adding a platin. So there is no denying that. The reason they didn't have a good response is because they decided to skip the chemotherapy drug and then again still carry on with the remaining drugs in the protocol. In comparison, the other trials, which including the brightness trial and the other one, I can't recollect the name now, but in both of those trials, what they had done is that they had delayed treatment cycles, but they continued with all the chemo drugs. So the anti-tumor effect seems to be maximally correlating with how much dose you are able to go through rather than absolutely trying to stick to a certain schedule. So if you could actually manage the patient to go through all the platin and the taxanes, even if the patient's chemo cycles are delayed by a few days or a week or so, there was definitely an improvement in the PAT-CR rates of adding platin. Surprisingly, in both the trials, it was immaterial of the BRCA. In fact, BRCA positive patients and BRCA negative, the BRCA negative patients fared better with the platins, which was quite surprising in all these NACT trials, all 3 of them. So those are interesting.
If you allow me one more input.
Yes.
If finances are not a barrier, then Pembro also has been attempted, and we in fact used in one patient, and that patient's tumor was huge and it was like stony heart tumor. And after giving taxane, platinum, and Pembro, the tumor was again, it is looking like same initially soft and then it has become harder. And we discussed in our multidisciplinary tumor board, and final decision was that since it was non-metastatic disease also, even after this all Pembro 4 cycles, we finally took a chance that we will operate upon. And it was PET-CR, there was no viable disease. So Pembro, if finances are not a barrier.
So, sir, exactly on that line. Like I said, I dealt with a similar case yesterday. So young lady, I was treating her TNBC, no family history, BRCA negative. I completed 4 cycles of AC. The tumor was shrinking. I went on to my first cycle of taxane, but then she said that, look, the tumor, when the दूसरे cycle तब जितना कम हुआ था वहीं है. So I got the imaging done, and while it was not progressed, it was not stable, it was responding, but TNBC really shrinks when it shrinks. And that was not the case. So in addition to the I gave her the options, and now so she's just taken her first cycle, which was I added a platin and I added pembrolizumab. There is evidence for that. It's a young lady, if you want, try and affording. So, things we can consider. Anyway, coming back to our patients. So we have gone through NACT, we have gone through paclitaxel, we have done an MRM. There is residual disease with 2 of 10 lymph nodes positive. They decided not to give her capecitabine, but having said that, now she's come back after 7 months with shortness of breath. The PET-CT unfortunately now shows multiple bilateral pulmonary nodules, large ones, largest one being 2 centimeter. So where do we go from here? Dr. Avinash? First question, would you repeat a biopsy? TNBC 7 months back?
Yes. if given a choice, if I have a biopsiable lesion, I'll go ahead. So about 13 to 25% of them could have change in either ERPR or HER2/neu. Let's assume they are turn out to be triple negative or biopsy is not feasible because it's just a pleural effusion and cell block getting difficult. So I'll choose my therapy between capecitabine and eribulin. In this case, it will be a closed third option because they have already progressed on anthracycline and taxanes, and given a choice, I'll prefer here eribulin compared to capecitabine.
So just curiously, everyone here would go for a biopsy?
I don't think so. For TNBC, there is not much in. If it was a hormone receptor positive,
Then most certainly we do a biopsy.
But in clinics, sir, most of the time we have to go because sometimes patient has also question.
Yeah, so assuming you have a patient who is rich and compliant, that magical patient, but assuming it is that, then will you do a biopsy in a TNBC which has come back after 7 months?
So for documentation purpose,
For documentation.
Agreed. In fact, we also do it routinely in that whenever possible, we do a biopsy and document that this is metastatic breast only. There is nothing, no other second primary or anything we have missed.
Recently, I have faced a situation where the neuroendocrine differentiation we have seen.
Yes.
Yeah, that's true. Those kind of
It's a
things
rare thing, but
absolutely.
sometimes you can.
So, but just curiously, like was pointed out, 15 to 20% of the cases, the ERPR and HER2 status can change. But how often have we actually seen a TNBC changing to anything else? You have?
I have not
seen. Me neither. I mean, okay. Change to HER2 positive. Interesting. So yes, but then if possible, patient willing, all of that, then why not do a biopsy? All right. So again, then coming back to it, next line of management, Dr. Lalit sir, what would your next choice be? Or would you first like to get certain tests done in this patient? In this case?
BRCA we will do if not done.
BRCA, yes, okay.
And eribulin will be the treatment of choice.
BRCA and eribulin. Anything else anyone would like to test for? Yeah.
You can do PDL1 IHC,
PDL1 IHC,
BRCA, if possible CPI, if possible MSI.
Okay. So, but do you expect, I mean, based on MSI in the first line, would you actually alter your treatment for any reason?
So there's very small chances of it coming MSI positive, especially in breast cohort. But if you want to list the test which could be done before getting into the final treatment of choice, it would be standing somewhere in the list. So first will be obviously PDL1 by IC, I'll prefer CPS, and then it comes the BRCA, and then it comes the MSI.
All right. So PDL1 and BRC testing. We'll get anybody else has anything else to add? So, okay, so we get PDL1 done, we get BRC done. Let's now, just for the sake of discussion, assume that this patient, she's gone through anthracycline, she's gone through taxane, she's... Yeah, sir.
What I feel is what people are doing in... So, definitely we should do BRCA, definitely we should do PDL1. These two are standard, but I think there is data coming up that besides BRCA, other hereditary genes also are actionable today, especially PALP2. So probably instead of doing BRCA, we should do an HRD. We don't know how TP53 is likely to have an effect. ATM, we don't know, but how CHEK2 will be having an effect. But PALP2, actually, somebody literally wants to coin it as BRCA3. So probably, and there is a role there. So probably, if it's possible, instead of BRCA2, we should do a full panel.
Absolutely. It's something like what happened in ovary. We went from BRCA to, PALB and RAD and all of that. So, okay, let's then assume that this patient has gone through BRCA. The BRCA is positive and the PDL1 score, CPS score is less than 1. What would be a line of management then? Dr. Saurabh?
Start with still with cytotoxics.
What would you go for?
Yeah, so actually eribulin is right now my choice.
So even if she is BRCA positive and a recurrence, you would still prefer for eribulin?
Yeah, because at least 2 lines.
For 2 lines, she's gone through anthracyclines and as the part of the
but it's a standard.
So no reason you wouldn't consider for platinum? I don't mean PARP. Okay. We are aware of the PARP part. So no, there is no PARP right now. There is not enough data in the first line.
If no platinum was used initially, and if it's a BRCA positive, then definitely platinum would be the right choice.
So platinum would be your choice. Everyone else on the panel? All right. So similarly, then if the patient is, similarly, if the patient, let's assume again, BRCA positive, but in this case, now the PDL1 score, CPS score is more than 10. So where do we go from here then? Dr. Lalit, sir? PDL1 CPS more than 10, BRCA still positive.
Difficult, in fact, for me.
I will prefer chemo plus immuno, basically.
Chemo plus immunotherapy. All right. Everyone agrees with that? Then pembrolizumab with, we can combine it with...
So I would like to add here, a similar case was discussed this year in ASCO.
All right.
So if there is a choice of chemo, probably single drug carbo. And if we want to use, like if the CPS is more than 10, then carboplatin plus pembrolizumab.
Absolutely. I think
Or
just
gem
summarized it.
carbo pembrolizumab was the consensus.
Absolutely. Sir has wonderfully summarized. That's what we do. So CPS score is high and BRC is positive. We go for platinum based with the immunotherapy. If the CPS score is more than 10 and she's not BRCA positive, then your combination would be immunotherapy with any preferred chemo drug. In that case, pembrolizumab with, so that, yeah.
Sometimes nab-paclitaxel.
Nab-pacli, Carbogem.
Immunogenic.
Absolutely.
And that's why.
All right, fair enough. So that's what we would do. So this now talks about, we are just going to go through some of the data about why combination works and doesn't work. We are aware that in most cases we would avoid combination. There are two things we'll discuss. One is capecitabine with ixavepilone. They've tried randomized trial where they tried just the drug ixavepilone or they combined it with capecitabine. Again, we don't really do this routinely. I am not aware. I have not used the drug. The other combination is nab-pacli with bevacizumab, pacli with bevacizumab, and again, ixavepilone with bevacizumab. Anybody here has any experience of using bevacizumab in breast cancer in combination? The answer would be no. So we don't do that really. Only thing,
even Salil, the dose of capecitabine, they mentioned 2,500 mg per meter square. So in practice, we face difficulties in metastatic disease with this much doses.
Metastatic, no, I don't think anywhere we would be able to reach those kind of doses. Absolutely. So the only interesting thing I found in this was this part that, of course, this was with Bevasi, but the median PFS, if you noticed, because we do believe that nab-pacli for some reason is while adds more toxicity is more beneficial in PFS, but at least in this data we see paclitaxel did just as fine as nab-pacli. So I thought that was the only useful thing that I derived from this. And if you look at the toxicity profiles, in the first year, if you look dose reductions by third cycle, you'll see. So if you are considering paclitaxel versus nab-paclitaxel, I'll not leave ICSA in this. 45% chances that you're going to reduce your dose if you're using nab-pacli. So because we sometimes are interested in let's go for nab-paclitaxel instead of pacli, but really no reason. Paclitaxel dose reduction chances are only 15%. In the other cumulative discontinuation by cycle, again, now don't get confused by the colors. First they went for blue for nab, now they've gone for green for nab. But if you see, overall paclitaxel really does better. Paclitaxel is well tolerated. The PFS is equivalent to nab-paclitaxel. So if at all we are considering taxanes, the patient has not used them before, paclitaxel is a good choice to begin with. Then coming to eribulin, the drug that we are to discuss. So firstly, let me just ask, when do you use eribulin in your practice and what is your experience, Dr. Amit?
Surely, till recent times we are using in the fourth line or fifth line, but now switching over earlier.
Now there is more data. And how has your experience been with using eribulin in the fourth line?
Most patient goes only for 4 to 5 seconds.
Doesn't tolerate it all that.
Yes. Agreeable, in fact, that we do not use as second line. We use only a third or fourth line or as the last drug, where it becomes difficult. The response is also not good, not prolonged, and we also feel that the drug is probably not working well.
True, very true. I think everyone will share that experience, Dr. Avinash.
Actually, I have a similar patient with pleural effusion progression on 2 lines. She just has finished 4 cycles and it was CR on CT scan with eribulin.
Wonderful. So yes, there is a role for eribulin. We all agree it's one of those few drugs which after multiple lines of chemotherapy still shows a survival benefit, which is wonderful. It's not too often that you have a metastatic patient going through 2 or 3 lines and then still saying that, there is something we can offer. But yes, like everyone here has pointed out, most of these patients have gone through multiple lines. Tolerability is really poor. Toxicities, the peripheral neuropathies, the neutropenias, all of these things are very difficult to manage. Should we be taking it up the order? Probably yes, we should. So this is a comparison of eribulin. I'll just go to the part where they have eribulin versus physician's choice of drug. Clearly there is an OS benefit. The median OS is 10.6 versus 13.1. We all agree that in a metastatic setting that's not bad. So eribulin is a good drug. Probably we should consider maybe moving it upwards towards second line or so, and try using it when our patient actually can tolerate that kind of toxicity. So again, the same independent review versus the investigator's review, they were talking about the PFS. Clearly there is a PFS benefit. We are looking at around 2.2 versus 3.7 months. And again, even in the investigator's review, it was nearly same. Adverse effects, like we just all discussed, what are the common ones? Neuropathy is a problem. Majority of your patients will have already gone through taxanes. You add eribulin to that, it's a very difficult thing to manage. Neutropenia is a very common. Already your marrow is, at this point quite suppressed because of the multiple lines. So these are the common problems that I face. Alopecia at this point also, of course, does not matter so much. Any particular side effect or any? Yeah.
So platinum treated patient, difficult management of anemia is there.
Difficult
Always
management of
the
anemia.
hemoglobin rounds up around 8, 7, 7, 8.
Very true. Yeah. So hematological toxicities and neuropathies, I think that would summarize the problems faced. So another interesting thing, now this is quite fascinating. So this trial compared eribulin versus capecitabine in patients who had gone at least through anthracyclines and taxanes, have received 2 cycles or more, 2 or more lines of chemotherapy. Overall, this talks about all breast, this talks about ER, PR, all of that together. You would see capecitabine really didn't do all that bad, compared to eribulin. If you look at it as a whole, capecitabine actually has done quite okay. If you look at the median OS, it is 14.5 versus 15.9 months. Capecitabine has really held itself. And if you look at the fact that easier administration, patients get to be at home, come OPD basis, I mean, it's really not such a bad option. My personal experience, honestly, with capecitabine is really good, for TNBC especially.
Cost is very important.
Cost is a fantastic thing in addition. Your experiences, Lalisa, with capecitabine?
Yeah, in fact, this works very well. Yeah. Of course, the doses, we are not that aggressive in metastatic setting, but the convenience, ease, and sometimes, in fact, we modify that rather than giving it 2 weeks on, 1 week off. We modify 3 weeks on and then like 20 and 10 days. So you take it for 20 days, 10 days break. So the patient comes once in 1 month, and it works very well.
Works very well, I agree.
And sometimes, in fact, in patients who are compromised, financial compromise, we use, in fact, methotrexate also along with that. Like CMF, we have used CMF during our days. In fact, that was one of the best, fantastic working chemotherapy regimen. So still we use the oral modification of that. So sometimes we use cyclophosphamide, methotrexate, and capecitabine. So that also works very well in TNBCs.
So there is in fact trials on low dose capecitabine in long duration along with endoxazoline.
In fact, recently there is one published article last year, 21, I forgot the name, but they have compared capecitabine versus CMF like chemotherapy in patient with TNBC in adjuvant setting. In like after the PET-CR is not achieved, then rather than giving capecitabine alone, you give the CMF like regimen, and the response is much better.
Very interesting. Very interesting. So, the rest of the panel experience with capecitabine? Because I'm really happy with that drug on most occasions. It really works.
Yeah, so I'm happy. It works very well. There's a few things which I like to mention is that the trial mentioned doses of capecitabine is difficult to give in real world, number one. Number two, as in second or third cycle, by the time patient gets hand-foot syndrome, many of the women becomes less compliant to treatment. So we don't know after 4 cycles, after seeing initial response, this slow progression, and we ask, then they would have left or underdosed themselves quite frequently. And there's about few % of patients who have DPG deficiency, who have terrible hand, foot, and diarrhea. So if you take that part out, it's reasonably well drug.
Yeah.
Compliance could be sometimes an issue.
I agree. Okay, so just looking at the toxicities overall that we face, we are aware of these things: paclitaxel, hematological toxicities, and the neuropathy. Docetaxel, similarly, hematological toxicities, which can be quite significant, and the asthenia and the neuropathies. Capecitabine, I've had a decent experience. Hematological, not so bad. Hand-foot syndrome, of course. NAMP-PACLI, hematological, and the neuropathies. Gemcitabine as a single agent, probably we are not going to use it really up the scale. Ixabepilon, no experience whatsoever. Eribulin, now more and more experience coming up. I have a couple of patients where I've tried. It has worked well. It is difficult to manage because unfortunately my mindset is still that those cycles with 3 lines when after that, eribulin comes to mind that needs to perhaps be modified. It's a difficult drug to tolerate. So back to our patient. So if this patient was ER positive, HER2 negative, and had significant liver mets, would your management change? Or would you still go for chemotherapy? Is there any other way of approaching it? Would you still consider the combination? How would you approach this?
So, is there a visceral crisis or not? We have to see first.
Correct. So significant liver mets in this case. I will assume that she is impending liver crisis.
So in that case, I will prefer with cytotoxics.
Cytotoxics drugs. So in this case, anything that would change your mind, or would you still say eribulin is, especially I think some data before I just came, they showed about how it works in ER/PR positive also.
No, it has showed the benefit, but yes, combination chemotherapy to be discussed because the patient is in impending organ dysfunctions. So sometimes we should prefer for initial response, combination chemotherapy also.
Lalit sir?
Agreed, combination chemotherapy followed by hormone directed therapy.
Combination followed by then hormone later on. Dr. Avinash?
I'd like to have a bit of caution about how much the bilirubin is high and how much the alkaline phosphatase is high. More than 3 bilirubin and more than 5 times OTPT, I'll be really cautious to use doublet of chemotherapy here.
So interesting that you brought that up. So let's assume that this patient has liver dysfunction, which is bilirubin of around 3. OTPT slightly on the higher side, let's assume it's somewhere between 70s and 90s. Then would it change your line of management? Which drugs would you prefer if your patient was having liver dysfunction, where you are assuming it would be a problem? Taxanes would be your preferred, yeah? Everyone here would go for taxanes in case of liver dysfunction?
No, docetaxel I will not prefer, never.
Docetaxel you
yeah,
will not
because they have a severe diarrhea and neutropenia and liver dysfunction.
Right. So dosi, no, after bilirubin is more than 3, I would not touch dosi.
So taxanes are usually a problem with, Lalit sir?
Even with anthracyclines, I'll be like...
Correct. So then your...
I'll prefer
Gemcitabine, platinums.
Gemcitabine and platinums. Yeah, that's okay.
Gemcitabine also with smalling with the lower doses, since we are dealing with a metastatic disease impending liver failure. Yeah. So we will be using initially say 50% dose, gradually seeing how the patient behaves.
Absolutely. So dose reductions agreed, but I think if your bilirubin is going 3 and above, you'll probably end up not having to give taxanes. I think probably in this case, then platins with gem or something might work better in that case. All right.
I have used a single agent cisplatin. It works
single agent cisplatin.
Well. Or a paclitaxel also at a flat dose of 80 or 100 mg is
works fine. Fair enough. So single agent cisplatin, flat doses of paclitaxel. Eribulin, we keep coming back to eribulin. So yes, okay, but OS benefit of eribulin was seen in all cases. It was, of course, TNBC is where it has shown a really good benefit. But having said that, even irrespective of the ERPR status, irrespective of the HER2 status, yes, but I'm of course still cautious about not giving trastuzumab or, and I have never combined the two. Any experience of combining eribulin with trastuzumab? Anybody here?
Sometimes clinical situations comes where we have
perhaps
to
in the
combine
future.
this. Yeah.
Yeah. So again, never had that experience. I agree. If required, perhaps we might have to. I have never used it in ERPR positive, nor have I used it. My entire experience of eribulin is just based on TNBC. Anybody here has used eribulin in an ERPR positive, HER2 negative patient with METs? None.
Used, but in very later lines.
Very later lines of treatment. So again, it's same. Yeah. Now, so, just to summarize, yeah. I'm sorry, I just summarize absolutely fast. Antibulin agents have been supplanted by anthracyclines. We don't use generally anthracyclines as first line anymore. We agree it's either taxanes or platins. First line antibulin, weekly paclitaxel, that is what we prefer. No one goes for 3 weekly again, 3 weekly docetaxel. Fair enough. Weekly example, no evidence, no experience. NAP Pacli, these are not more effective than Pacli. Neurotoxicity is common with weekly regimens of Pacli. Combination anti-HER2 should always be considered in that case. Second line eribulin, please remember. So I think, and no advantage of eribulin over capecitabine overall all breast cancer patients combined. All right, so that's about it. Thank you.
Thank you.
Thank you so much for the Thanks.
All right. Thank you very much. Thank you everybody for staying with us. A lot of people virtually whole day. It was really a great event. And as Dr. Ashok Ved expressed, that probably this was a good meeting because it was really a real, true case-based discussion where we could discuss our real life and we could discuss real cases and how it actually happens in the real world. So thank you again. I would like to thank you on behalf of Indian Society of Oncology for taking active participation. And at the end, I would like to thank Viatris also for supporting this engagement. Thank you very much. Only one more message before you leave. Please do not forget to collect your mementos from the outer desk. Thank you very much.